Good evening, everybody. Welcome to the 9th International Conference on Cardiology, Diabetology, Electrocardiology, and Critical Care. All of us know medical science is a rapidly changing field where yesterday's fact may become matter for the archive to store, and today's fact may not find agreement with experts of tomorrow. So continuing medical education is an integral part of medical profession. This CME will cover diverse aspects of cardiology to be delivered by experts of national and international repute, and I'm sure you will enjoy the flashes of expertise during this course, and I'm sure the proceedings of the conference will contribute immensely towards better patient care. The first talk is by Dr. Professor Navin C Nanda from the United States. He will be talking on lung ultrasound, a new kid on the block for cardiologists. Dr. Navin C Nanda, all of us know, he is a distinguished professor of medicine and cardiovascular disease, University of Alabama, Birmingham, Alabama, USA. He has been hailed as the father of echocardiography, father of modern echocardiography by many prestigious organizations and societies because of his pioneering work in adult, pediatric, fetal, and peripheral ultrasound. Echocardiography labs and institutions have been named after him in India, and he's the founder and the current president of the International Society of Cardiovascular Ultrasound, and he has a masterly approach of solely unmasking the depth of the problem. So I'll hand over the mic to Dr. Dayasagar Rao to conduct this session. Dr. Dayasagar Rao, please.
Good evening, Dr. Manoria and Dr. Navin Nanda. I think there is no need to elaborate and waste time. I think may I request Dr. Nanda to speak on the role of examining the lung for a heart disease through ultrasound. This is a new kid on the block, and we would like to hear what exactly it tells us hemodynamic-wise, and whether we can differentiate a cardiogenic from the non-cardiogenic pulmonary edema. I'm sure he's going to enlighten and then tell us more facts about it. Over to you, Dr. Nanda.
Thank you very much. May I share my screen? Okay, looks like everything is working. It's a great honor and privilege for me to be at this conference. And as you know, Dr. Manoria is not only a pioneer in cardiology in India, but also a pioneer in arranging so many different conferences, and Dr. Dayasagar also. Well, my topic is going to be on lung ultrasound. And first of all, actually, when you do lung ultrasound, remember, except for a small area, everything is covered by lung in the chest, and one needs to examine not only the front of the chest, but also the back of the chest, and also laterally in the chest, especially when the patient is supine. You can look at the anterior, just like you see that here. So it should be a comprehensive examination. And it's just to show you some zones, you can name them, like anterior zone, lateral zones on the right lung, and the same thing you can do on the left lung. And just to show you that you can examine from the back also, many times with the patient sitting up. So it's very important to examine all zones using both transverse and longitudinal transducer positions. Failure to do longitudinal examination may miss some echo findings, and the probe should be kept perpendicular to the skin. Can use routine cardiac or curvilinear abdominal probes, but linear probes provide the best resolution of the near field structure. So those are preferable, but you can use cardiac probes also. And pulse and color Doppler can be used to detect intrapulmonary shunts as well as vasculature when there is consolidation and other lung conditions. So normally, actually, because of the high acoustic impedance mismatch between air in the lung and soft tissues, ultrasound waves will not penetrate the lung tissue because it contains air. At the same time, it gets reflected from the pleura. So therefore, the pleura presents as a bright hyperechoic line. And below this, one sees many artifacts. Those are actually the parallel, mostly equidistant parallel transverse linear artifacts are visualized, and these are called A lines, and they represent a normal finding. So these are actually artifacts. So you can see here the reverberation artifacts. With a transducer, you get the first echo, and then it gets reflected back and may get reflected 3 or 4 more times, and you will get actually parallel lines below the pleura, but they are all reflections from the pleura itself. So here, if you look on the left side here, you see these A lines. You have the pleural line very clearly seen, very bright. You can see that. And below that, you get equidistant transverse lines, which are the A lines. And at the same time, you get rib shadowing here. There are 2 ribs here, and they would have these black areas, which are due to rib shadowing. On the other hand, when there is water in the lungs, like extracellular water in the lungs, then you actually get these different type of artifacts, which are called B lines. They're comet-like artifacts. They're something like in a dark room, if you take a flashlight torch and you move around, that's how that looks like. And these are actually B lines, and those are pathological if they are 3 or more in number. And they can also be, depending upon the amount of the water there in the lungs, as well as the pathology, they can coalesce together, and like this, many B lines can come together as one line, or they can completely present as a white surface, white thing, and these are multiple B lines all getting together, coalescing together, so you can see this. And this also means there's more water or there's more lung pathology in a particular patient. So what are these lung B lines? They are actually due to subpleural interlobar septa thickened by edema, that's water, or there could be some interstitial edema also. That's what causes these B lines. They are, as I mentioned before, longitudinal, linear, comet-like, well-defined artifacts originating from pleural line. They also cause disappearance of A lines. When there are B lines, the A lines disappear. And they must extend all the way down in the sector image, and they're pathological if 3 or more are present. They may be more confluent, as I mentioned to you. The confluent B lines may be there. The greater the amount of fluid and more severe the disease process when you have confluent lines. Now remember, if you see vertical lines, they're not very fragmented. They are not complete. They are not really B lines, and they do not go all the way down to the full depth of the sector. They are called actually Z lines, and they are not non-diagnostic. So the B lines must go all the way down to the sector. Now, what is how the B lines are formed? Well, we don't know exactly, but there is one theory that it is actually you have to have fluid trapped in a tetrahedron of air bubbles, like you can see here. So there's fluid here and there are air bubbles, and these produce these reflections, and that's why you get these B lines, vertical artifacts. So this was done in a in vitro setting, using bubbles in a water bath. They were able to check this out, and there's actually a horn or bugle-shaped fluid collection, and these actually are converted by electronic processing into these individual bands called B lines. Now, what are the entities that produce B lines? Number one is, of course, water or fluid in the lungs, like when you have acute pulmonary edema, or fluid overload also may do that. But inflammation can do that also. For example, in acute respiratory distress syndrome, or ARDS, you can get that pneumonia, infection, pneumonitis, lung injury. Fibrosis can do that, as I mentioned earlier, interstitial lung disease, chronic, pulmonary fibrosis, and trauma, something like lung condition. So many pathologies can actually produce B lines. Now, in cardiology, in a cardiac patient, if you know that the patient does not have any lung problems, and you get these B lines, that would mean actually acute pulmonary edema. Now that can be subclinical, which means you may not hear any crackles or may not hear any rales at all, and yet there may be fluid in the lungs. So that is where the utility of lung ultrasound comes in, to detect subpleural, subclinical pulmonary edema, as well as, of course, pulmonary edema in patients. For example, in patients with high, heart failure with preserved ejection fraction and heart failure, you'll be able to pick it up very well with the lung ultrasound. Now, this is just to show the difference between cardiac pulmonary edema and acute respiratory response, how you can tell the difference. Not exactly clear-cut all the time, but some points are very important. For example, in pulmonary edema, you have homogeneous B lines. They're also gravity-related distribution, while on the other hand, in ARDS, they're patchy, non-gravity-related distribution. Usually they're separated or coalescent when more severe. Here they're usually also separate, more coalescent. There is no spared area when there's pulmonary edema. You get it everywhere. But when there is ARDS or some other things like pneumonia, pneumonitis, there could be spared areas. So some areas may not show, some zones may not show any B lines. Not only that, the pleural line is very important. Usually it's thin and regular when there is a cardiac pulmonary edema. On the other hand, with AR, they're actually irregular and fragmented. So that also gives you a good hint about this. Not only that, cardiac pulmonary edema, the consolidations will be absent most of the time, while in acute respiratory distress syndrome, you see frequent small peripheral consolidations. Now, you need to remember that you will see consolidations or any pathology very close to the pleura, because deeper down, the ultrasound cannot penetrate because of lungs. So only in the subpleural areas you see that. Now, of course, in COVID-19 patients, most of them will have consolidation near the periphery of the lungs or at the bases, so they're easy to detect by lung ultrasound. Diffusion can be frequent, variable, usually transsudate, usually bilateral, often large on the right side, and usually when pleural effusion is not really large when there is acute respiratory distress syndrome. So now here to show an example here, this is a patient with consolidation, and what you get here, you get the consolidations are actually defined as something like a tissue. So you think of liver, when you do a subcostal examination, you can see liver as a tissue, the characteristics of liver that you see is same when you get lung consolidation here. And there can be some fluid in the consolidation called fluid bronchogram, and there will be some air trapped also here. So many times when you have consolidation, you also get these bright little areas. They're called air bronchograms. So that way you can easily recognize them. And of course, just to show an example of a pleural thickening, this is a very irregular thickened pleura, unlike what I showed you as linear pleura. So you can actually make a diagnosis of pleural abnormalities also. This is just to give you an idea that to show you that this can be very important. For example, when you have central illustration taken actually from a Journal of the American College of Cardiology here, and one can see these are the B lines here. There's some pleural effusion here, but again, to show that if you're suspecting in a clinical patient, a heart failure is there and ejection fraction is normal, that it becomes very useful. At that point in time, lung ultrasound can be done and you can diagnose pulmonary edema in those patients, some water, extra water in the lungs. Not only that, there is Dr. O, I think from Mayo Clinic, is the one thinking that it may be something when you diagnose diastolic function or diastolic heart failure, looking at this lung ultrasound B lines may be another criterion that you can use in the diagnosis, in addition to the E to A ratio, the tricuspid regurgitation velocity, high tricuspid regurgitation velocity 2.9 or more, and of course, looking at the lateral and E-wall, lateral and medial wall velocities. Also, if you look at the end-stage renal disease, many patients do have renal problems. The pulmonary B lines are seen even when lung crackles on auscultation are absent, or even when the peripheral edema is absent. Not only that, pulmonary B lines are more sensitive than chest X-ray for pulmonary edema, and the number of B line artifacts correlates with the all-cause mortality, cardiovascular events, and hospitalization. As you can see here, B lines less than 15, B lines 15 to 60, and when the B lines are more than 60, you actually look at the survival here is much worse than when the B lines are less in number. So lung ultrasound is actually safe, quick, low cost, no radiation, reproducible, can be repeated many times. A full examination may take up to 20 minutes if you do a very comprehensive exam. Can you hear me?
Yes, yes.
No. Full exam may take up to 20 minutes, but most of the time it doesn't take more than 5 or 10 minutes. Can follow dynamic changes in pulmonary lung and lung consolidation. For example, if the pulmonary edema gets less, the B lines will decrease in number. Now, of course, there are no validation studies done. I mean, comprehensive validation studies done in lung ultrasound, but there are many reports in the literature suggesting its usefulness. So remember that it's not something that has been put in stone about lung ultrasound, written in stone, but still very, very useful. And it may also identify the best structure for puncture in the pleural effusion, and that is very, very important. Now, one of the things to remember is you only examine the periphery of the lungs. You cannot go very deep. So any pathology which is near the periphery of the lungs is what you get. That is a big limitation. And of course, they found it's not really a risk factor for death. At least some studies have shown that, but others have shown different different results. So lung ultrasound scores can be done. I mean, you can take the scores in different zones, and if you gather with the clinical findings, the arterial oxygen levels may actually differentiate patients who may require intensive care, admission to CCU, mechanical ventilation, or mortality also in patients with COVID-19. So obviously in COVID-19, lung ultrasound is very, very useful. And actually some of the things like peripheral pathology it may be even more sensitive. Lung ultrasound may be even more sensitive than CT for these subpleural abnormalities. And of course, CT needs transportation to another site. So lung ultrasound can be done at the bedside here. And there's another study here done last year in October. It's an abstract. Lung ultrasound beats chest X-ray in COVID-19 diagnosis. The sensitivity of 97% as compared to chest X-ray, which is only around 69, 70%. Here's to show you very easy to diagnose pleural effusion here. This is actually a collapsed segment of the lung here, liver here. So look at the liver tissue, and if you have any consolidation, it looks like liver tissue, then you know that is consolidation in the lungs, just to give you an idea here that you can diagnose lung. Now, one other thing that you remember is that whenever you look at the pleural line, there is also sliding of the lung. Of course, the patient is breathing. So let us see here. This is very nice to see there's the skin here, and then you have subcutaneous tissue here. So that's another, and then you, of course, below that would be the muscle, and then you get the pleural line. It's not shown earlier, so I thought I'll show it here. And and the lung will slide also. Now, this is very important. When you see lung sliding, that means there cannot be any pneumothorax. There's very, very highly specific. You see lung sliding in that area, there is no pneumothorax. On the other hand, you look at this person here, the lung does not slide very much, very little motion, the patient is trying to breathe. Here you can make a diagnosis of pneumothorax. Now, this is not specific for pneumothorax because there are other pathologies like when the pleura gets stuck together, both the parietal and visceral pleura get stuck together, then you may not actually, and then also this may produce. So the sliding, you can definitely exclude pneumothorax. When you see no sliding, mostly maybe pneumothorax, but other pathologies can occur. But here is again you can see there is hardly any sliding here, no movement of the lung at all here. Some little movement, but nothing very much. But if you actually see a patient where there is no absent lung sliding here, at the same time at another region here in the same place you can see lung sliding, you have a little lung point between the absence of lung sliding and the presence of lung sliding. If you get that particular point, then that is very specific for pneumothorax. So that's again another thing one can diagnose when you do a cardiac exam, patient is short of breath, pneumothorax can also be. Just to show here, actually what happens is that if an M mode may also be useful here. Generally, when you see M mode, they call it seashore appearance. So they see it like some water here, some waves, and then you get this sand-like thing. So an M mode, this is a normal appearance. But when you have pneumothorax, then nothing is moving, so everything is parallel here. So this becomes like a barcode, which you have on many of the grocery items. So when you see a barcode appearance, that means maybe a pneumothorax. And when you see a sandy beach appearance, that means it's a normal, no pneumothorax. So just to give you some idea about this also. Now you can examine the blood vessels in the lungs also. For example, in intrapleural shunts, or sometimes in consolidation, they have blood vessels also. And when you see this, you have you can identify a pulmonary artery because it is a high resistance with very little flow in diastole here. On the other hand, when you have a bronchial artery, that you can see as a low resistance, which means diastolic waveforms are also very prominent as compared to the systolic waveform, as opposed to the pulmonary. Now that intrapleural shunts is something recent because they also can cause dyspnea in a patient. Now that has just very few papers have been published on that, so some more work is needed. I think I'm practically over almost time here. Thank you very much for your kind attention.
Thank you, Dr. Nanda. Can you hear me, sir?
Yes, I can hear you very well.
Dr. Ashamuthi. Yeah. So thank you for your beautiful presentation. You have made the difficult topic very easily and simpler to understand, as we are all really, we are not doing practically the lung ultrasound. And also you can differentiate easily the patients from pulmonary edema and from the non-cardiac causes with the lung pathology, and is a very useful tool for the patients with COVID. 19.
Thank
Giving
you,
almost, yeah,
Dr. Nanda, for making it so simple,
yeah.
crystal clear, and a very new application, but in reference to COVID. Of course, we recollect the B lines on the X-ray chest, but this is something at the bedside, maybe in critical times. Only one query: how do you obtain patient cooperation? Because these are the patients sometimes in distress.
No, they actually don't need to have that much of patient cooperation, because if they're a ventilator, they're supine, and you can examine the lung supine. You can't go posteriorly, but you can laterally and you can go anteriorly. So that's very, very easy to do. So as I mentioned earlier, you can do it in supine patients also. As a matter of fact, many people don't even look at the back of the patient. They look
Okay.
at the front and the lateral walls. Yeah, so that's easy.
Because now in COVID, we have to give the reverse position, which is useful for the respiratory relief.
Yes, absolutely.
Prone position.
Thank you very much. Thank you.
Dr.
Thank
Dayasagar Rao, any comments?
Dr. Nanda, I have one question. Has this lung ultrasound, has it come into the guidelines as a method of diagnosing pulmonary edema?
No, it hasn't come into the guidelines yet. And I think just like many things, like, for example, strain hasn't come into the guidelines either, although we are using it all the time. So guidelines will take some longer time. And also, remember, guidelines are not guidelines.
Yeah, sure.
Guidelines are just guidelines. They are not guidelines. Very important to remember that also.
Yeah,
So don't follow guidelines blindly.
Thank
No,
you,
no,
Dr. Nanda.
A very
Thank you,
important
Dr.
term
Nanda.
that you introduced was subclinical pulmonary edema. That is something very.
Dr. Nanda, lung ultrasound has been routinely done by the intensivists for so many years, but it has not become so popular with the cardiologists, even at the present state of time. Any specific reasons? The intensivists are doing almost daily.
No, I think there's no real reason except that one doesn't know that much, and one is not very sure. One hasn't any experience with that. But anytime when you do a cardiac examination, you just move to the lung and look at it as the lung. Easy to do that. As a matter of fact, we try to avoid the lungs, no? Right? When you do a cardiac exam, so you are looking at lung many times. In any case.
Looking at its utility, should it be included in the cardiac training for the cardiologist, the lung ultrasound?
I think it should be done. I mean, although, in many cases, the lung ultrasound is done by either radiologists or intensivists, or in the CCU or in the intensive care units or in the emergency department. But I think it's useful to do a routine exam. Like we used to, when we do a cardiac examination, many people do not used to do suprasternal or suprasternal examination, supraclavicular examination, or abdominal exam. Now we are doing that. So I think it'll be easy to really incorporate that in the training.
And what is the learning curve for lung ultrasound? How much time it takes?
Not that much, really. Not that much, actually, because maybe you can learn in 1 hour, 1 hour, 2 hours. And if it's pathology patients, you can take a little longer. But it is not very difficult to do. Remember, though, it's better to take a linear probe, though. Linear probe give you a much better resolution than cardiac probe. But cardiac probe work too.
Dr. Dayasagar Rao, any?
Yeah, I think finally, what is your class 1 recommendation for lung ultrasound as things stand today by a cardiologist? When do you recommend it?
Yeah, I think my recommendation is that anytime you suspect that the patient may have subclinical or pulmonary edema, I think that would be a good way to do it. And of course, you have to exclude some lung pathologies, but you're not thinking of lung pathologies, many of these patients. For example, patient who is heart failure with preserved ejection fraction, it can become very, very useful there. As also the Mayo Clinic people are suggesting that there should be one of the criteria to be used in addition to all the other criteria we have. Okay. So that's the one you can go through. But at the same time, I think nothing wrong in looking at pneumothorax, consolidation, other things which are peripheral consolidation. We can take a look at those also very easily, as I mentioned. By the way, what I'm just showing right now is the lung consolidation with air bronchograms.
I think a day may come wherein instead of looking at the chest X-ray, we may have to look at the lung ultrasound.
Also,
yeah, the sensitivity is more, as Dr. Nanda has mentioned, 96% almost, compared to X-ray chest only 67%.
Right.
Given a very clear picture.
Especially when you have a portable chest X-ray, it's even worse,
Yeah.
Portable setting, in an intensive care unit.
That's great. That's great. Yeah.
Any specific role for pulmonary angio? Yeah, pulmonary embolism?
Pulmonary embolism, not really that much actually, except if you get these, like if there's it blocks, pulmonary artery is blocked and you get some consolidation, then you'll be able to see that. But I've not seen too much of studies done for pulmonary embolism. There actually, when we look at the right heart function and the right ventricular dilatation, that's much more right now going on rather than looking at the lung ultrasound. But it can help with some empyema and some other lung pathologies where you may get, for example, here you get this consolidation and you put the color Doppler on, you may see color and you may do a pulse Doppler, you can see some blood vessels, those are there. But we don't want to go too much into the lung pathologies as much as into the pulmonary edema portion from the cardiologist point of view.
Dr. Nanda, one question, that the pregnancy complicating with the cardiac diseases, sometimes it is difficult to, we cannot submit the patient for the X-ray and all that. Will this will be a useful tool for differentiating pneumothorax and plus because the breathlessness is seen throughout the trimester as compared to the cardiac cases in pneumothorax and other asthmatic conditions and all. So in such situation, will it be a useful tool?
Yes, absolutely. Pneumothorax is very good actually to diagnose because you can see the sliding is not there. I showed you that. And if you see sliding, of course you have to use, pneumothorax can be all localized. So you have to use different zones. And if you find that there is a sliding everywhere, then there cannot be any pneumothorax in that patient. On the other, the sliding is absent and some very rare lag pathology is excluded, especially you get that lung point, where you see sliding and no sliding, you can make a more specific diagnosis of pneumothorax. Okay. Yeah, very, very useful, I think.
Yeah, yes.
Dr. Nanda, Dr. Nanda, just one question. I think it is a ICU-based preliminary investigation and does not substitute the definitive investigations. So that is how I look at it. Your comments.
Yeah, definitely. I don't think lung ultrasound by itself, well, sometimes by itself it may give you a diagnosis right away. For example, I'm suspecting there may be subclinical pulmonary edema, then lung ultrasound will right away. But in many other cases, you put all things together. I mean, as we all do, we don't just look at one technique. In any technique, we go into clinical, we look at other portions, history of the patient, and then we use the echo or other techniques. So once in a while, this technique by itself may be very useful. But I think the best way to do that is all we do. We never look at one technique and depend on one technique. We look at the whole clinical picture, history, and then we look at the technique. That's how we should do it.
Complementary.
Exactly.
So if there are no questions, we move on to the second lecture. Thank you, Dr. Nanda, for an
Thank you,
excellent
sir.
Thank you, Dr. Nanda.
Applause for Dr. Nanda for his beautiful lecture and very informative and made it very so simple. I thank Dr. Manoria for giving me the opportunity to chair a very great chairperson for the Dr. Navin Nanda session. Thank you so much, sir.
Thank you so much.
Dr. Manoria. Yeah.
So the next session is on heart failure. And the speaker for this session is Dr. Amrish Agrawal from UAE. Dr. Amrish Agrawal is my dear and near friend. He's a senior consultant cardiologist and associate professor of medicine, Fujairah Hospital, UAE. He has more than 25 years experience in Australia, India, and UAE. He's invited faculty and speaker in international meetings such as the Euro-ECO, World Congress across the globe, and ACC and ESC meeting. He has more than 20 publications in peer-reviewed journals. He's author of several chapters and books, an international member of the editorial board, and he has been the principal investigator for international studies and registries such as Garfield, Flo, Goal, and so forth. The chairpersons for this session are Dr. Sudhakar Kancharia, Dr. Sushil Kumbat, Dr. Pankaj Manoria could not join because of emergency. So I'll hand over the mic to Dr. Sudhakar Kancharia to conduct this session. Dr. Sudhakar, please.
Good evening to all of you. Thanks for giving this opportunity as a chairperson in this session. And my sincere thanks to Dr. Manoria and other committee members also. So today's topic is, has time come to leave diagnostic based on ejection fraction in heart failure. So previously we have been doing some investigations like echocardiogram and some other MRI or some nuclear scans to know about the ejection fraction in heart failures. So now recently we have some other things like in the cardiac power indexes and other estimations. So depending upon those things, can we leave these investigations or not? I think that is the topic right now. So I welcome Dr. Amrish Agrawal to start the program and enlighten us about this topic. Thank you.
Thank you very much for the introduction. So today I'm going to go a little bit on the clinical based topic. As the time come to leave diagnostic behind on EF and the heart failure, the question is that does ejection fraction calculation in the clinical practice matters? All of us know that as the time is going and the heart becomes sick, a time comes when eventually all the heart fails. And that is why as the treatment modalities across coronary artery disease, hypertension, diabetes.
Dr. Amrish, please speak little loudly.
Yes, as the conditions of heart failure, diabetes mellitus, ischemic heart disease, hypertensions are getting treated and improved over these times, more and more population across the world are actually landing in the heart failure group. So heart failure management is one of the very, very important management which a clinician or a cardiologist does in the practice. So this heart failure has been defined by a number of societies over the years, but they have not really agreed upon. For example, you will see that the European Society of 2016, American of 2013, and Japanese Society, they have the same concept they're all talking about, but the definitions vary differentially by the number of words. And these words tell you that people really don't agree upon what exactly is the heart failure. So in the beginning of this year, all the societies in the 6 countries and 14 countries and 6 continents, they gathered together to put together the universal definition and the classification heart failure. And this included societies from America, Europe, Japanese, and even the Indian societies, they also participated in this one. And they said heart failure is a clinical syndrome with symptoms and signs caused by structural and functional cardiac abnormalities. Well, this is not different what the definition Brownwell gave us when I was in medical school, and corroborated by elevated BNP, which is a new thing, and the objective evidence of systemic and a pulmonary congestion. And one of the objective evidence of pulmonary congestion is what Dr. Nair described is the lung ultrasound in their practice. So over these times, the cardiologists have decided to phenotype heart failure, and the European Society in 2016, and which was modified in 2019, divided phenotypically heart failure into 3 groups: the one with a reduced EF, the one with a preserved EF, and the one with a mid-range ejection fraction. And they put the cutoffs of 40% as the reduced EF, more than 50% of preserved EF, and anything between they were called mid-range EF. And now this has been put synonymously and equal to the American classification as the mildly reduced EF. In the 2021 guidelines, the European societies actually put 4 pillars of heart failure, which Dr. Manoria will speak subsequently on more. But the more important thing is that they put in the classification that the RAS inhibitors led by ARNI should be the class A indication. And if ARNI cannot be used, they put that ACE inhibitors or the ARB can be considered. And the American classification and the American guidelines were nearly similar. In the patient with a symptomatic heart failure with a reduced EF, so remember all these European, the American classifications were for the reduced EF, that means EF of 40% or less, they preferred ARNI as over the ACE inhibitor ARB, over the class of the drugs as the RAS inhibitors if you use the patient with heart failure. The reason being is that there is a substantial data which came from paradigm trial and other trials which showed that ARNI in the populations of the reduced EF was far more superior to ACE inhibitor enalapril, and that is the reason ARNI is supposed to be a class 1 indicator. Subsequently, more data has come regarding ARNI in the class, and this data, we will not go into details, but there are 2 studies which talked about the biomechanistic mechanisms which actually told us that this ARNI therapy can be extended beyond 45%. And there is a reason to believe that this extension of this therapy can go up to the range of 55% in this population. Among them, the PROVE heart failure trial included nearly 734 patients, and they looked at the various parameters with ARNI, and they found in this population with a reduced EF, they found that as the EF kept on improving over this time, so 25% of the population, they had actually an improvement in the ejection fraction over this times. The indices which indicates the LV dysfunction and the indices of the left ventricular remodeling, they kept on improving. So you can see that the left ventricular end diastolic volume and the left ventricular end systolic volume decrease over this time. So this was the data from the PROVE-IT trial. There are a number of problems by using ejection fraction as a division for in the patients with heart failure. For example, if you see what is the normal ejection fraction, the position paper by American Society of Echocardiography and the European Society, they put in their study that the normal EF is 52% and beyond for the men and 54% for the and beyond for the women. The reason the women have a higher cutoff for the normal ejection fraction is that the women have a smaller body mass and they have a smaller end diastolic volume. So when the denominator is on the lower side, obviously the ratio becomes higher. So this is not the 40% with the American and the European societies guidelines for the heart failure they put in the practice, but the normal EF by these societies are 52% and 74%. Then there are a number of other reasons for the ejection fraction using is a problem for the clinical practice, because we all know that what we measure ejection fraction is actually the radial function of the heart, but there's a longitudinal function and the torsional functions which are not actually quantified by the ejection fraction we use in our clinical practice. There is a wide range of patient variability. There is a wide range of intra and intra-observer variability. So it is possible that what we see a mid-range or the mildly reduced EF of 40 to 49% can be as wide as 30 to 59%. And what of the clinical trials? The clinical trials also have a population of heart failure which is bimodal based. So we have a predominance of the population which is on the lower side, and we have predominance of the population which is on the upper side. And this population, which in the mid-range, is not much spoken about in the clinical population. And it is possible, and the trials have used different cutoffs for the preserved EF. So some people use 40%, some people use 50%. So it is not clear when we compare the studies, are the studies comparing same apple to apple, or they are comparing apple to oranges, or they are comparing green apple to the orange apple. So there's a mixed bag of population we see in the clinical practice. Patients don't come to us with a label that we are the preserved EF and we are the reduced EF. So there was a very nicely conducted study funded in USA. It was called an ARIC study. And this ARIC study, they rigorously defined how they defined ejection fraction by having a standard laboratories where each and every patient was scrutinized, seen by multiple cardiologists, and a consensus was agreed. So in this study, they found that those people who were classified at the mid-range or the mildly reduced ejection fraction between 40 to 50%, when they were restudied and reclassified, to astonishment, 40% of the population had a different outcome. Only 21% of the people were downgraded to the EF of less than 40%, and nearly 20% were downgraded to were upgraded to the EF of more than 40 or more than 50%. So it appears that when we take a numerical point cutoff values in the ejection fraction, this ejection gives us a band, but it's not very clearly. And when you work in a hospital like I'm working in, there are multiple doctors, you will see in the morning meeting the same patient which have been characterized by a cardiologist 1 month back as the EF of 45%, and the same echo done 1 month later says that EF has reduced 30%. And you wonder, what is the reason to have this the patient left ventricular function deteriorate? Or is it possible that the two cardiologists, there are different variations in the same ejection fraction, what they saw in the clinical practice? But as a clinician who go bedside to treat the patients, what are we concerned? We are concerned with whatever cutoff we take. Is this cutoff will give us to some therapies which are useful, or is this cutoff will give us to therapies which are not useful? So from the clinician point of view, we are having actually two categories. The one with the red, in which there are a lot of standard therapies which are found to be useful. This is the EF of reduced EF of less than 40%, and a big category of chunk of populations which are having therapies which are gray areas, are not found to be useful, and this includes the EF of 40 to 45%. And above, so it appears that the division of the heart failure in the phenotypic categories of less than 40% and more than 40% has some utilities, because we have a clear historical evidence or some trials showing clear evidence of benefit in the red zone of less than 40%. So what about the population with the preserved EF? And the preserved EF is unfortunately a little bit difficult practice to see. As you can see, the position guidelines statements from the guidelines of 2012 and 2016. In 2012, the guidelines said the same thing which repeated in 2016. No treatment has been yet to shown convincingly to reduce the morbidity and mortality in the patients with the heart failure with a preserved EF. And even in the mid-range EF, there is some data to show, but the guidelines are not convinced about this data. So from 2021 document, you can see in these patients who are decompensated heart failure, so this class 2 and 4, with a mildly reduced EF, they are saying that all the existing therapies, ACE inhibitors, ARB, beta blockers, are actually class 2AB recommendation, That means that you can use it, but the guidelines are not clear, are going to work or not work. So you may think that this position, what has happened, may have changed in 2021. So the universal definition for the heart failure, which like discussed with you in the beginning of the year, persisted with the phenotypically dividing the heart failure into the EF of 40%, 41 to 49%, and more than 50%. So they maintain the same categories or what were discussed for last many years, but they put a new category, which is called as the heart failure with the improved ejection fraction. That means these are the patients who started with a baseline ejection fraction of less than 40%, and subsequently with the treatment or the left ventricular improvement over time, function improvement over time, there is an improvement in the EF of a 10-point increase from the baseline EF, and the second measurement was more than 40%. This category they divided and said this label should be put as the name as the heart failure with the improved ejection fraction. So when the patient comes to us, can we look at the patient and can we characterize this patient that you come in this category, this phenotype? The answer is no, because number of trials have shown that clinically we cannot really distinguish a population with a preserved EF, mid-range EF, or the reduced EF without doing some investigations like an X-ray, which may show cardiomegaly, or an echocardiography, which can divide the EF. So you can see this data from the charmed investigators, which actually included multiple populations in which there were a population with a reduced ejection fraction, and there were alternative charm, and there was added charm, and they showed whether you take the parameters edema, orthopnea, PND, rest, there is no way to discriminate in this population with the different categories of the heart failure. Similarly, the outcome-wise, the data shows very clearly that the people with preserved EF, they do as badly as the population with a reduced ejection fraction, making us to believe a preserved ejection fraction does not implicate a preserved outcome. So the preserved EF people also do as badly as the population with the reduced EF. So if the therapies were working equally, we will not even divide the population with the ejection fraction. We will label them as totally as a single ejection heart failure and treat them accordingly. It is because the historical trials have shown that some therapies, they do work better, they work better in the population with the reduced EF. That is why the societies and guidelines over these years have divided the population into reduced EF and the preserved EF. But the guidelines and the treatment over this time have shown reasonably clearly that the therapies which work in the reduced EF, but in the clinical trial were shown to be neutral or not effective in the population with a preserved EF. So you can see whether you look at the ACE inhibitor, ARB, or whether you take carbidopa, beta blockers, digoxin, spironolactone, and all, you can see actually the results in the population with a preserved ejection fraction for neutral. And that is why the guidelines, like I told you, they said there is no therapy which has been found to be working in the population with a preserved EF. Similarly, the newer therapies which are found to be encouraging in the population with the heart failure, for example, you talk about sildenafil, nitrates, ivabradine, or vericiguat, when they were studied in the population of the preserved EF, they were found to be neutral or not effective at all. So this led to dismay in the general cardiologist population that we are able to treat only half of the population heart failure with the effective therapy. Another half of the populations, we can do more lifestyle modification, we can modify the risk factors, but there is nothing in our hand to offer this population except some few kind words. However, the things have changed in the last 12 months or 16 months, and there are a lot of green shoots which are coming. And these green shoots allow us to look at the data more objectively and to see there are certain therapies are able to work in the population of the preserved ejection fraction, because all these times we are dividing this population as a preserved EF as a homogeneous population, then anything more than 50% come to the same category. But now the cardiologists are able to phenotypically divide this population to the preserved EF into certain other categories. And what are these categories? So one of these trials which showed a discrimination or the dichotomy in the treatment was the CHARM program trial. And you can see when you take all the CHARM trial, the CHARM reduced, the CHARM added to the CHARM alternative, and you put as a linear variation to the ejection fraction and the treatment effect. So the bottom chart is the ejection fraction, and the y-axis is the treatment effect. You can see that the composite endpoint of heart cardiovascular death and the heart failure hospitalization, and even the heart failure hospitalization, the benefit continued beyond the reduced EF. You can see the reduced EF is on the left side of the blue bar, the mid-range is the blue bar, and on the right side of the blue bar is the preserved EF. So it seems that from the data that beyond 50%, up to 50 to 55%, there is a benefit of candesartan in the heart failure population. the benefit does not stop at 40%, although the nadir is seen below 40%, but the benefit continues to happen, and the confidence line crosses unity at the level of 50 to 55%. Similarly, the data which came from the spironolactone trial in the TopCut trial, which looked at the variation. So the TopCut trial was a very large trial, which looked at the population of more than 55%, but the trial was conducted, has showed a geographical distribution. For example, the population from USA showed a lot of benefit, but the population which is studied in Georgia did not show benefit, and there are a number of reasons for it. But when you plot the similar population at the ejection fraction versus the treatment effect, you can see the benefit of spironolactone in the population with heart failure continued in this population around 55%. So it appears that the 55% is something which is consistently shown in the trial of the TopCut trial as with the trial for the CHARM trial. Similarly, the data which came out from certain other studies, for example, the Paramount trial, which was done in the ejection fraction of more than 45%, and they found that when you give this population Entresto, which is RNA, there is actually the improvement in the NT-proBNP, improved in the left atrial size, improved in the NYHA classification over these times, indicating a mechanistic benefit of Entresto in this population. And this makes us to believe it is possible that this population may show some benefit in the clinical outcome. And for this reason, a trial was designed, which is called the Paragon Heart Failure Trial, which was really 2019, included nearly 4,300 population with a symptomatic heart failure, and which a class 2 plus with a EF of 45% plus. And in this population, the drug, which was a secubitril valsartan, was compared to an active treatment moiety valsartan. So it's not considered as placebo, was pitted against valsartan. And what did the result show? The result showed that the primary endpoint, which was a composite endpoint of total heart failure hospitalization, and the cardiovascular death was reduced by 13%. So this showed an improvement, but this p-value was just missed. This p-value just missed by 0.059%. You know, 0.05 is significant. So the p-value just missed significance. But when the data was analyzed once again, and this was a pre-specified versus cardiovascular death and the heart failure hospitalization, you can see that there is a meaningful reduction in the heart failure hospitalization, although cardiovascular death was similar in the two arms. But we know that the cardiovascular death in any clinical trial is the function of the long duration of the trial. So once the heart failure hospitalization reduced, it is certainly possible if the more number of patients was enrolled or the trial was done longer enough, you may find some differences in the cardiovascular death. So certain other meta-analysis, certain other multivariate analysis were done in the population, the paradigm trial. And it seems that when they look at the population, the female population, and those people with the ejection fraction of 57% or below 57%, there is a 22% reduction in the primary endpoint. So once again, we are able to see a differentiation between the point of benefit. So the equipoise point is around 57% seen in the Paragon heart failure trial, similar to what we saw in the TopCut trial and the CHARM trial. So once again, if you see the Paragon and the Paradigm trial, the Paradigm showed consistently benefit across all the ejection fraction of 50%, but the Paragon trial showed a benefit which is actually related to the degree of the ejection fraction. So the more lower the ejection fraction, below around 60 to 65%, more is the benefit. And a time comes where the benefit diminishes and there is no benefit. And it seems that this point comes to around 57%. So all the population, if you take around 9,000 patients which were included in the Paradigm trial and the Paragon trial, and you put the plot in the same way as the benefit ratio over the ejection fraction, you can say very, very clearly that the better benefit cutoff is at the level of 57%. At 57%, the benefit ratio crosses the unity line, and anything less than 57%, the population of the heart failure patient derives. So this trial slide shows you the benefit of commonly used therapy for the heart failure, whether it's Entresto or is a spironolactone or the beta blockers and the CHARM trial. And you can see in all these trials, there is a consistency of benefit which extends beyond 40%, but the upper limits of this benefit is not consistent. Some trials they show 57%, some trials show 55%, some show beta blockers on the lower side, and at 50% the effect diminishes, and the CHARM trial benefit continued. So it appears that our arbitrary division of 40% is erroneous, and we have to actually revise our point in above. The reason is that the heart failure has got certain modified outcomes and certain non-modified outcomes, and it appears that the 40% does not they captures everything in our clinical equation. So once the EF crosses 55%, there are certain non-modifiable outcomes, unknown or non-modifiable targets, and the comorbidities which actually outweighs the structural damage to the heart. And those people with the EF of less than 55%, they can have the same benefit from the therapies which are found beneficial in the population with the heart failure with the reduced EF. So question comes, what about the population benefit in the population with the new class of drugs with the SGLT inhibitors? We know the SGLT inhibitors in our wonder drug for diabetes, for the kidney failure outcome, for the heart failure outcome. And this slide is seen by everybody because the SGLT inhibitors shows consistent benefit in the population with the heart failure, with the reduced EF, with the reduction in the cardiovascular death, heart failure hospitalization, and the regular composite endpoint. So in 2021, in the European Society, which only concluded like 2 months back, the data from the Emperor Preserve trial was presented, and this trial showed a 21% reduction in the outcomes with empagliflozin over placebo, and this 21% reduction outcome was in the composite endpoint for the heart failure hospitalization and the cardiovascular death, mainly driven by reduction in the heart failure hospitalization. So in a very nice paper which was published by Milton Packer on the w.e.f. Emperor trial, and the title was Dissecting the Results of Emperor trial according to the ejection fraction, what we can learn, they showed that the Emperor reduced and the Emperor preserved had similar benefit. As you can see, the benefit was 21% in the Emperor preserved and was nearly 25% in the Emperor reduced. Similarly, the outcome benefit was seen in practically all the components, such as the time to the heart failure hospitalization, time to cardiovascular death, and the first and the recurrent hospitalization for the heart failure. So the benefit was seen neutrally, but what was remarkably seen is that there is a cutoff when the benefits diminishes, and this cutoff, it seems, crosses the line of around 64%. So it seems that our classification for the heart failure requires an upward revision. 40% is no more valid. We have to actually change this cutoff to 50% and the beyond 50%. So when you superimpose the outcome of the Emperor reduced trial and improved pooled analysis over the trial of the Secutor Versa trial, you can see they are actually running parallel to each other. In this graph, what we have seen from the circulation paper, that the blue bars represents the outcome of the Paragon trial, and the red one comes out from the Paragon Preserve trial, from the Emperor Preserve trial for Valsartan for empagliflozin. You can see they run parallel to each other, but the magnitude of benefit in for the empagliflozin was higher than that was seen by the Entresto, and all of this composite endpoint shows that around 62.5% is the point where the benefit tips to the no benefit side. So before 62.5%, all the population benefit. So in the LAM,
please summarize your time.
Yes, I will summarize now in one slide only. So in the one position paper by Lamb and Scott Salmon, which looked at what is the classification heart failure according to the ejection fraction, they said very simply 40% and below is the reduced EF. But the other one with the normal EF, no more preserved EF, they said we should write at the normal EF should be made as a cutoff of 55% or more in the men and 60% or more in the women, because we know that the EF in the woman is is higher. And anything in this blue bar, in the red bar, and the blue bar and the green bar is the population with a mildly reduced ejection fraction. And with this, I come to the end of my slide by saying there is a consensus and clarity on the treatment of the reduced EF, but heart failure with a mildly reduced EF and the preserved EF, which is the population without reduced EF, are oftenly ignored. They are very, very important group because they combine, they contribute, and they are approximately 50% of the population with heart failure. But we know now the benefit of therapies which were actually ignored extend beyond to those with a reduced EF and mostly reaching a cutoff point of 55 to 57%. So it seems that there is now is the time to revise the cutoff for the ejection fraction for the heart failure with a reduced EF. So thank you very much for your attention.
Thank you so much, Dr. Amrish Agrawal. A very nice presentation, and I think it's a very complicated topic, ejection fraction based treatment of heart failure. And you have mentioned one point here is I think we have to take care of even the preserved heart failure also, along with reduced heart failure. So now the topic is open for discussion.
Dr. Any comments?
Very nice presentation.
Dr. Amrish, a small question from my side. Actually, when you are diagnosing this preserved heart failure, so which investigation is very useful, and what parameter you want to take it to say it is a preserved heart failure?
So when you, in order to label a patient with a preserved EF, you have to certify certain criteria. First is the clinical presence of heart failure by clinical and by pro-BNP. The second is the structure abnormality of the heart. That means a preserved EF on the ejection fraction, dilatation left atrium, or if you do a Doppler indices and issue a tissue Doppler, you can have classify the population with a preserved EF. So just by EF is not enough. Important to have a clinical basis, elevated biomarkers, and certain Doppler parameters.
Dr. Amrish, this is Dr. Rajeev Agrawal, and I'm impressed with the simplicity of the talk, but I have a simple suggestion from my side as a clinician that if we make the cutoff at 55 and remove the altogether concept of mid-range, by and large, therapies behave in the same direction. It is a question of incremental benefit. You are on a lower side, you do better, vis-a-vis if you are between 45, 50. So like any other biomarker, higher is the risk, more is the yield. So what is the great point in making a subclass mid-range ejection fraction, but by and large, qualitatively, the behavior of that class is like HFrEF. I need your comments.
Yes. So the concept of HFrEF came in because of the reason of the trials. Because when the people started looking at the trials, they had to take some cutoff. They choose the cutoff in which the therapies can be shown to have a clear benefit. And those historically, they found the EF of 40% or less, they can show therapy. So if you take the ARNI trials, if you take the ACE trials, and if you take INTEREST trials and SGLT trials, they all continued with a 40% cutoff to show benefit. And everything more than 40%, they lumped in one group. This group as a total did not show any benefit. And they said that these therapies are not useful at all in this group. But now the people are started to dissect out this group, and they say this group is not a universal identical phenotype. The lower end of the group behaves like a heart failure with a reduced EF. Upper end of the group behaves like a population with these therapies are not found to be useful. Now we have come to this equilibrium point is around 55%. So I think what will happen, a time will come, you will find that the guidelines will say that the therapy is working less than 55%, therapy is not working 55%.
Yeah, it's so simple.
If you see the labeling of the interest by the FDA, the FDA have removed the word totally any reference to the cutoff, numerical cutoff in their recommendation, and they say when the clinician finds that the person is in heart failure and they supported by biomarker evidence, you can start interest in this topic.
Thank you. I think ejection fraction, if you are not estimating by 3D echocardiography, certainly has many limitations. But time has not come to say bye-bye to ejection fraction, but all your criteria for ICD, all your criteria for CRT, even the classification at the present time, the universal definition is based on ejection fractions. So ejection fraction at the moment will continue in near future also. Maybe in times to come, you can utilize other modalities. GLS may come up.
Dr. Manoria is very much correct. People are not going to amend the EF. They are going to just revise the cut of the EF. That's all what will happen.
So, Dr. Kombat, any comments from the chairperson, Dr. Kombat? Any other questions? So now we thank you, Dr. Agrawal, for the wonderful talk. Please, we now move on to the next talk, and this is on lipid modulation for prevention of ASCVD with a special reference to secondary prevention, the progress made so far. The chairpersons for this session are Dr. S.M. Bandurwala, Dr. Sangram Brother, and all of us know Dr. Rajeev Agrawal is Chairman, Department of Cardiology at the Jaswant Rai Specialty Hospital, Meerut. He has interest in preventive as well as invasive cardiology, particularly diabetic vascular disease. He has received several awards like Amar Ujala National Excellence Award for the Lifetime Achievement 2017, Lifetime Achievement Award by the IMA Meerut Inspiring Doctor of Cardiology 2018 by the Economic Times, and Literacy Excellence Honor 2018 by Bharat Nirman. His department implants 3 pacemakers for the needy people and holds the Limba Book of Records for implanting the maximum numbers of 3 pacemakers in India. I'll hand over this session to Dr. Bandukwala to conduct it. Dr. Bandukwala, please. Dr. Bandukwala, you're on mute. Please unmute.
Thank you very much, Professor Manoria, for asking me to chair this session along with my colleagues. I think the last 2 sessions were very, very informative, and we are eagerly waiting to hear from Professor Rajeev on how to prevent SCVD, the interaction between lipid modulation and the prevention of SCVD. Over to you, Professor Rajeev.
Thank you, Dr. Manoria. Thank you, Dr. Bandukwala. It is a pleasure to be with you all and learn from each other in different aspects of cardio-diabetology. I'm going to speak on lipid modulation, especially in secondary prevention and the progress made so far. And as you know, today you can't live without artificial intelligence. And so my presentation will have some reflections, overtones on genetic modification. I have tried my best to make it clinical, simple, so that you can carry home. And this is some kind of very latest update on different aspects of lipid modification. I always believe we have to understand beyond artery cleaning, and we have to understand that arterial healing is more important than arterial cleaning. I'm a strong believer that atherosclerosis never sleeps. This is the disease of the vessel wall. It is not the disease of the lumen, which is one expression of the disease. So do not get carried away by luminal obstruction. You have far bigger burden of atherosclerosis in luminal wall. Look at any kind of trial in last 30 years, except in acute coronary syndrome, the metabolic manipulation of the disease has overscored or at least equaled the interventional manipulation. So I strongly believe in chronic stable angina, metabolic manipulation is the key to success. There are various ways to metabolic manipulate the disease, but till today, I have no hesitation in saying that lipid modification scores over all and above. We have abundance of literature, proof, outcome studies, visual studies like OCT images, IVUS, and every kind of documentation to ascertain that this is the way to treat atherosclerosis. Just to empower you that it is not a clinical outcome. The lipid modification changes atherosclerosis. These are near-infrared spectroscopy images, and this is 1 month of lipid modification, and you can see the lipid have disappeared from the atherosclerotic plaque, and justifying that plaque is very, very high likelihood of getting stabilized. The hygiene studies just recently presented shows that PCSK9 on OCT improves the thickness of the plaque, thereby making the fibrous cap, thereby making it a stable plaque. Not only in acute coronary syndrome, in chronic coronary syndrome, you can see disappearance of ischemia on stress imaging by treating metabolically the disease. And these are the images which should empower you that what you are doing is something real, practical, and purposeful. I am a strong believer that we have to move from LDL reduction to LDL eradication. And I believe that we may approach a day where zero LDL hypothesis may be a reality. Despite all this, the challenge is 10% of the patient in Europe receive combination therapy and 1% only receive PCSK9. So there is a huge gap of performance. And that is what is This is Michelangelo study from Dr. Kaushik Ray, and you can imagine what we must be doing in developing countries on the basis of ignorance and cost effectiveness. And the most purposeful thing I often say, lipidology is best needed by interventional cardiologists because they deal the highest risk patient population. And that is why the yield is maximum. And if you look how we define high risk patient population, there are various scores, and you know, high risk and very high risk ASCVD population behave differently. VHR or very high risk population has got higher event rate, and naturally it is going to be benefited more. And this is just a recent study on PCSK9, who will be likely to be benefited most. Again, Antonio Goto devised a method more than 20%. Framingham risk score, you call it secondary prevention. But let me say there are various shades, and there are ways to say that there is high burden 20 to 29, 30 to 39, and patients who have extremely high burden, that the ASCVD risk of 10 years is more than 40%. So ladies and gentlemen, the secondary prevention is not a homogeneous group. We have to sub-stratify it to get the best result to our patient population. Never forget lower extremities. If the patient has got expression of disease in lower extremity, whether it is asymptomatic, symptomatic, obstructive, or mutilating, they all carry very, very bad prognosis. So this is an editorial we'll talk about peripheral arterial disease is not a peripheral issue, but it's a central issue. It's talking about aggressive systemic atherosclerosis. What are the targets? We have to develop newer strategies. You know, the LDL level is coming down and down, and this is the only biomarker where the lower is better. Leave us any other biomarker, whether the sugar, blood pressure, or sodium, any other thing. There is a U-shaped curve, but till today we have a one-way curve. There is no U curve in LDL. And you know, the risk keeps on decreasing as the LDL level goes down in Fourier and Odyssey. The another good concept to carry home is if you do 25% reduction in LDL from 160 to 20, the risk reduction is 20% because the baseline risk is high. So LDL alone is not important. What is important is the baseline risk, which you should calculate. So same 25% risk reduction from 67 to 50, the absolute risk reduction will be 8%. So one should again understand baseline LDL and the reduction in LDL. And you can understand if you do 50% LDL reduction, if your baseline risk is 200, LDL is 200, you achieve 190, you achieve 95, the number needed to treat in high risk population is just 10. But if the baseline LDL is 70, and if you do 50% risk reduction, you achieve 35 LDL, and number needed to treat is 26. So look at this, 190 to 70, same 50% reduction result in different NNTs. And this is another study which is recently published, very important study, that whatever it is, if you do 50% reduction, the residual risk is very minimum. So I think the baseline you should touch is 50% reduction in LDL. The story is very complicated because the targets are getting tougher and tougher. We have started talking 1.4 or 1 in European guidelines. Indian guideline preceded earlier, and they say target LDL 30 milligram in extremely high risk group patient which have recurrence of event within 1 year, or in class A who has got coronary artery disease with multiple risk factor or diabetes. So this is optional, but this is mandatory, and LI has gone ahead of any guideline in the world who talked about 30 based on 4-year data. You cannot achieve this. You have to understand that you have to create combination like you heart failure today, like you do in hypertension. So if you are dealing with high risk patient who has got a high baseline, you know how much is the predicted risk LDL level to be achieved. So high dose statin with ezetimibe will create something like 60%, almost the same as produced by PCSK9. So that is the chart you should carry home, that we need to do combination chemotherapy in these goals. And the same thing, that if you achieve 1.4, probably all of these patients will need high dose statin and monoclonal antibody or ezetimibe. I often say today statin alone will not work. You need to MIBD or MABD your patient to achieve the targets. This is the first line therapy now, because you know your targets are very different. What are the future drugs? You know, bempedoic acid works a step before on the cholesterol synthesis pathway. Similarly, peripherally PCSK9 inhibitor. If you work on messenger RNA, more proximality is inclisiran. If you work still more proximal, that means you modify gene, it becomes gene seizures. I will talk about it a little later. Then on triglyceride modification, we have ApoC3 inhibitors or angiopoietin 3 protein like 3 evanacumab. Again, they work on lipoprotein lipase and endothelial lipase, which are involved in hydrolysis of triglyceride-rich containing proteins, which are very, very atherogenic. You know all that the lower the better. Odyssey outcome has also shown the same thing. PCSK9 produced something like 60% reduction. And the another good thing to understand it, at low level of LDL, PCSK9 only works when the LPA is high. That is another very important thing, that if you have achieved LDL of 70, if you want to bring it to 30 or 40, use PCSK9. It will be only effective if LPA is high. The cutoff is 13.7. So that is another important denominator if you are using PCSK9. Orient trial, we need outcome data. Again, it is being used now and it has come to the community use. Dr. Kaushik has tweeted several times that he has started using in his patients in UK. Bempedoic acid, I told you, is a good drug. We need outcome data from clear group of studies, and then we know that what will be the outcome. But at the moment, we know it reduces CRP, it reduces LDL on top of statins and ezetimibe. And if you combine all three, it can produce something like 65% of LDL reduction, and you will be able to achieve less than 17, more than 90% of patients. The gene therapy I talked about is once and done approach. This is gene Caesar, what is called as a CRISPR technology. And this is likely to be the future because it is one-time modification and lifetime you achieve is a knockoff of messenger RNA for PCSK9. And they are working on PCSK9 and ApoC3. And this is in vitro editing. Now we have data from monkeys and primates that they give it once and the rest of the life, their LDLs are low. So it is not weekly, bi-weekly, twice a month in PCSK9, 6 monthly in inclisiran, and maybe once in lifetime with these gene Caesars. The triglyceride-rich protein remains a new Achilles heel. As the particle gets lower, smaller and smaller, denser, the triglyceride content gets lower, but at the other end, you have big particles which are rich in triglycerides. Triglycerides are more inflammatory than LDL. So don't think triglycerides are innocuous bystander. And we have reduced it, which shows that in patient with diabetes, either a patient with CVD or with diabetes and other risk factor, statin therapy with 2 grams twice a day of EPA shows good primary and secondary outcome. The baseline triglycerides were not important. Triglyceride in this trial were more like a marker. But recently, Dr. Christy Ballantyne and Deepak Bhatt has published data which takes into account the baseline triglyceride also and show that baseline triglyceride also correlate with the outcome in reduce it. And reduce it interim, they show the effects, they start coming at 2 years, both in primary and secondary outcome. So the algorithm today is maximally tolerated statin, ezetimibe, EPA, and PCSK9, depending upon what kind of subset you have. If PG rich is there, you have EPA. If you have high LPA, you have PCSK9. The practical guidance is statin, ezetimibe story, everybody knows. If you have still high TG, you can consider fenofibrate. These are ESC guidelines, or you can consider high dose. It is class 2A because there is only one trial on which the documentation or evidence is based. Strength is against it, although it was a different trial. So the indication is class 2A. And when you use EPA, remember it can cause atrial fibrillation. Fenofibrate, we are waiting for lipid triglyceride modification. I think early next year, we will have the fenofibrate specific triglyceride lowering trial. The genetic tools on the block, we can bypass the LDL receptor. And I told you, angiopoietin like protein 3 with monoclonal antibody, the way you block PCSK9, it shows marked reduction in triglyceride, reduction in LDL, it shows improvement in HDL, and we need to have longer outcome data. So newer therapies are working like this, and you know, not only LDL, but all these big particles also contribute to atherosclerosis. So if we modify them, they will definitely result in improvement in atherosclerosis. We need to have an outcome data. Volanesorsen is another thing which work on ApoC3, and it reduces up to 75% of triglyceride. They are all monoclonal antibody which bypass LDL. Altogether new thinking, and you can imagine PCSK9 and these combination can be dramatic, but we don't have data on that combination till today. You can use these nanoparticles in modifying angiopoietin protein like 3. So what is the current status of triglyceride modification after intensifying statin therapy? If you need triglyceride lowering therapy, you can go to EPA, you can go to angiopoietin 3 like inhibitor, or you can go to ApoC3 inhibitor, but they have to take longer time to come in a standard guideline. I'll just end up that this story is not just a story, it is a reality. This is one of my patients in February who had this RCA, went ICD and bypass, and within 1.5 years, he comes back to me with this lesion because his LDL was never bothered. In fact, he was in follow-up the surgeon, and LDL moved from 93 to 121. This guy had LDL of 121 when he came back to me. So we did angioplasty and did the job, and you can imagine that how much suffering it is in the community by neglecting LDL, because these patients, they come back to you again and again. And I say lipidology is most needed by interventional cardiologists. We are at the verge of curing arteriosclerosis. We are not pacifying the plaque. And I'll say this is a diagram I have taken from diabetes care, SGLT2 and GLP-1 receptor. What they show that incremental cost in the beginning results in great dividends subsequently because the longevity of life has increased. I believe that same formula applies to lipidology. If you give combination therapy in the beginning of the disease, probably patients live longer now to enjoy the dividends for the investment they made in the beginning of the treatment. So I will say that investing in such patient in modifying lipid has got a far-reaching effects beyond considering the embarrassment to the patient and the clinician when there is recurrence of the disease. The same slide I'm going to end up, atherosclerosis, never sleep, is a disease of the vessel wall, and it is a metabolic disease. The mechanical treatment just resets the clock. Ladies and gentlemen, I ask you, call upon you to vehemently chase with all vengeance LDL. LDL is the culprit, and if you can modify triglyceride, it will be bonus on top of it. Triglyceride therapy modification is taking shape, and I'm sure in times to come, it will be in another tool in our hands. And you must read genetics today because all these new tools will come on genetic platforms. So I'll end up my presentation by William Osler, who used to say a good physician treat the disease and great physician treat the patient. Had William Osler been alive today, his quote would have been, "A good physician treats stenosis and great physician treat the atherosclerosis." Ladies and gentlemen, I call upon you to become a great physician and treat atherosclerosis, which is a reality and a clinical availability of these tools in our hands. Never, never forget that the treatment of atherosclerosis is lipid modification, and it is a very, very important, powerful tool in your hands. Thank you very much.
Professor Rajeev, it was an amazingly crystal clear presentation and concise and in a short period of time. I'm very happy to be here to listen to your presentation, and I am with you because for a long period of time I was saying that in a busy practice, if you want to look at the lipid profile, just look at LDL, don't look at anything else, and lower the better. Now we have proved with all the data that our main target should be LDL and lower the better, and we have medication to get on target, and especially the treatment paradigm moves from a single agent at a higher dosing to a tolerable dose goes to a combination therapy, as we do in diabetes as well. And I'm also happy that you brought in the cardiology platform triglyceride back on the anvil, that you need to, especially in a diabetic patient, you need to get a triglyceride down to modify the ASCVD mix. Thank you very much for being with us today. We have observation from Dr. Abhay Pandey that in this ASCVD modification, what is the role of low HDL, and does the European studies can be extrapolated in the Indian population? Dr. Rajeev, we can have your comments.
HDL had been in a lot of controversy recently, and people have started believing that HDL is a mysterious molecule. It still doesn't have much role in atherosclerosis, except in epidemiological data, where the high HDL is associated with low coronary artery disease. In fact, HDL itself has a U-shaped curve with atherosclerosis. HDL doesn't have a curve like LDL. So if you have very high HDL, I think more than 77 or so, if I am correct, the atherosclerosis increases. So HDL modification therapy, both with niacin, fenofibrate, has failed us. CETP inhibitors have failed us. Anacetrapib has failed us. So HDL therapies are at crossroad. The major emphasis is LDL, and on top of it, triglyceride modification, and pemafibrate and the newer tool like angiopoietin protein like structure 3 will be the future. And ApoC3 modification, I think PCSK9 inhibitor and triglyceride modification should be a key to success in resistant atherosclerosis.
Sir, Dr. Pandey also asks whether the European studies could be extrapolated to the Indian population.
Oh, yes. You don't have any data where you have shown that HDL, increasing HDL has improved the outcomes. So once you don't have data, it is our imagination. We are brought up with the understanding that HDL is protective. So we have to get away. We have to get away from this. It is notional, like we all believe that we can't give lipid lowering to 10-year-old child for familial hypercholesteremia. So I think there is no Indian data I am aware in terms of outcome. Epidemiological data is fine, but outcome data doesn't exist. And in the absence of that, it is emotional, notional that raising HDL is important, because phenotype B, if your triglycerides are high, HDL goes down. That is how it behaves. There is a bipolar relationship between the two. So the culprit is triglyceride, chylomicron remnants, triglyceride-rich proteins. We earlier believed because of their bigger size, they can't enter the subintimal space. Now we know they can enter through the gap junctions. They can go through the endospherocytosis, across the vessel wall, across the endothelial cells. They have been shown to induce atherosclerosis. So I'll say HDL is different, and I'm not focused at the moment in times to come if data is there, I'll be talking about that. But at the moment, it is LDL and triglyceride. There are trials which talk about cholesterol efflux capacity and all those things, but they are struggling hard, delipidated HDL, and then improving Apomilano trial, but they have not seen the light on large population-based data. I think the focus today is LDL, and we are fortunate we have cheap ezetimibe, we have cheap statin. At least if you use 40 milligram of rosuvastatin and 10 milligram of ezetimibe, 70% of your patient will be achieving targets. And don't get on to 10, 20 milligram of thing. Younger the patient, more the aggression. Atherosclerosis, you have stented one artery, rest of the artery shows non-obstructive plaque. He's the patient who need LDL 30. He needs the patient who need LDL up to 20. The Fourier data has shown there is incremental relationship beyond 10 milligram. So up to 10 milligram, you can safely go down. That is how I look at it.
Sir, what is your take on LA guidelines? Lipid Association of India issued a consensus guidelines of LDL.
No, I refer to them. They are 30 and they are the first guideline in the international scene which talked about 30, which is a 4-year data. No, the maximum you can come is European guideline, 1 millimole, 40 milligram in a very high risk group, and that too class 2 BA indication. I think LI guidelines are very aggressive, realistic, and community friendly.
Nowadays, a lot of talk is for lipoprotein A compared to LDL. What is your take on that lipoprotein A?
That is another dimension. As I told you, there are several things. LPA intervention, again with monoclonal antibody, their trials are going on. We need to have outcome data. Short of that, what is the recommendation or the guidance to clinician? Today it is LDL, LDL, LDL.
Dr. Rajeev, the reduced trial is often shown as a trial for benefit of lowering triglycerides. But if you look at the subgroup analysis, less than 150 triglycerides, similar benefit compared to more than 150. So the benefit does not seem to be related to lowering of triglycerides.
I agree with you, and I always used to feel that reduce it is not a triglyceride lowering trial. It is just a marker that if you are high triglyceride, you have a marker for persistent atherosclerosis. But recently I came across a slide of Christy Valentine and Deepak Bhatt where they have shown quintiles like LDL, and the benefit is related to that. So I agree with you. That is how I looked at it. But I have shown you one slide from Christy Valentine. He is no smaller person who has shown different quintiles behaving differently, and higher the triglyceride, better is the outcome. I have shown you that slide. But consensus is more or less what you say. It is more vasculoprotective, antiplatelet, and many effects which we don't know, vascular integrity, endothelial health. So I agree with you, but this slide challenged that concept.
The other issue is, are PCSK9 inhibitors underutilized only because of cost or because of ignorance of physicians and cardiologists also?
I think it is because of cost. And if you are also partly right. I am yet to see a combination of rosuvastatin or atorvastatin with ezetimibe in my geography. I just don't see. Because the titration of LDL is very, very poor. And I'll say more poor among the interventional cardiologists. The problem is interventional cardiologists feel that it is belittling to talk of LDL. They are not embraced when the patient comes back with restenosis or an appearance of a new lesion. So I personally feel it is an error of commission if your patient comes back with a lesion and LDL more than 30, 40. It's an error of commission and omission. So interventional cardiologists are just not practicing a simple tool like lipidology does not require any brain. Start statin with ezetimibe, majority of them will drop down. It is one of the simplest therapies, far more simpler than anti-diabetic therapy, anti-hypertensive therapy, where you have many players. It is one of the safest thing to do, and you need 1 or 2 titrations. But there is a lot of inertia, more so among the interventional cardiologists, because they feel small if they talk of LD.
Thank you, Dr. Agrawal, for the illustrative talk. Now we move on to the next session. And the next session is a dialogue session on a very common subject, clinical interventional cardiology for physicians. And the speaker for this session is no other person but Dr. Ashok Seth. The most striking feature of Dr. Ashok Seth is that he is an amalgam of an interventional cardiologist par excellence and equally excellent clinical cardiologist. And that personally I feel is the most appropriate introduction of Dr. Seth, although he is Chairman Fortis Escort Heart Institute, Delhi, Chairman Cardiological Council, Fortis Group of Hospital, awarded Padma Shri, Padma Bhushan, and B.C. Roy National Award, past President CSI, past Vice President APSC, President Asian Pacific Society of Interventional Cardiology, founder, director of several interventional cardiology foundations of India, like Heart Valve Foundation of India and Advanced Cardiovascular Interventions. Over the past 30 years, he has pioneered numerous angioplasty techniques for India and Asian Pacific region, and he has received several awards and ovations.
Thank you. Thank you, Professor Manoria. Pleasure to be here with you.
Thank you. All of us know atherothrombosis is the leading cause of cardiovascular morbidity and mortality. AMI is the #1 cause of death, and stroke is the #1 cause of disability. Atherothrombosis, as we know, has two components. A component of atherosclerosis, which you heard is driven predominantly by LDL cholesterol, and a thrombotic component, which is driven by platelet activation, activation of the coagulation cascade, and fibrin formation. At the present state of time, it is very, very clear that howsoever efficient the interventional cardiologist may be, the best PCI results, both in the immediate period as well as in the long-term follow-up, can be achieved only with incorporation of thrombocardiology and lipidology. So amalgam of clinical and interventional cardiology is the need of the hour. And therefore, the focus of attention today is on clinical interventional cardiology. Hello. For several years, we have been using more and more potent antithrombotic drugs to decrease ischemic events, but this has been associated with bleeding, and we know bleeding not only increases mortality in the in-hospital period, but there's also a 5-fold increase in one-year mortality. So prevention of bleeding has emerged as a new focus in ACS care. So Dr. Seth, when faced with a patient of high ischemic risk and high bleeding risk, say a patient of acute myocardial infarction, prior angioplasty, CKD, age more than 75, how do you balance the ischemic risk and the bleeding risk so as to reach the sweet spot? Dr. Seth, please.
Perfect, Dr. Manoria, great start. But before I start, I would also like to compliment Dr. Rajeev Agrawal on his great talk. I listened through the whole of it, and not just because I was waiting for my talk. Though he said interventional cardiologists are the ones most reluctant, I actually totally 200% do exactly what he said. And I just want to make one comment, which is important in terms of people understanding clinical interventional cardiology. When he said that you have absolutely no justification, or you should feel guilty if a patient had a recurrent MI or developed a new lesion within 1 or 2 years because an interventional cardiologist did not look at the lipids adequately enough. That is so correct. By the way, it is not uncommon, or it is known, that a patient has actually taken an interventional cardiologist to court for the fact that his lipid wasn't lowered between 2 instances. A younger patient who actually had lipids which could not come down to less than 85, LDL couldn't come down to less than 85, on the maximal tolerated doses of statins along with ezetimibe was not put on evolocumab. And 1.5 years later, progressed a lesion rapidly, resulting in another second MI, therefore deteriorating his LV function. He felt it was neglect, and that guideline-directed therapy had not been given to him to lower his cholesterol, LDL cholesterol at a young age, from 85 after having had an MI to the 40s and 30s, which could have prevented progression of disease in a second vessel and therefore prevented further deterioration of LV function. Now, that is the level that we got to understand. We owe it to our patients. It's our responsibility to get LDL cholesterols down extremely low. And I think not just every interventional cardiologist, every physician has a responsibility to do that. So Rajeev, I totally 100% agree with you. I second every word that you said. And I, as an interventional cardiologist, believe in cardiology first and interventional cardiology second. Now, coming to the point of balancing the bleeding risk versus ischemic risk. What's happened at the moment, and I would just tell that frankly to you, is over the last 10 years, the spectrum of the patients that we treat are getting older, more complex, multiple vessel disease, calcified lesions, left main, bifurcation lesions, and impaired LV function and CKD. So we're treating more complex patients, clearly, world around. It's also happening in our tier 2 cities with young interventional cardiologists treating ACS and MI, which has become their bread and butter. The most complex cases has become the bread and butter of our young interventional cardiologists because they're the first line interventional cardiologists. On the same side, these are elderly patients and have other comorbidities, leading they're frail, they're low underweight, they've had anemias, they're at high bleeding risk. More and more, what is very clear is that after angioplasty, after the first generation of stents, and the fact that Cypher and Taxus had also, as you withdrew antiplatelet therapy, high thrombogenicity, which was more related to the polymers and the thickness, actually led to an arbitrary decision of having dual antiplatelet therapy after PCI for a year. And it carried on from 2005, 2006 at a consensus meeting to the present era where the stents got better and better. We had better antithrombotic regimes. We had potent antithrombotic regimes. And we also had stent optimization through imaging, either using intravascular ultrasound or OCT. So clearly, the 1 year of dual antiplatelet therapy became a risk to the patient, at least a risk to many patients. So trials got done thereafter to show whether can we decrease this dual antiplatelet therapy and decrease the bleeding risk. And trials got done to say, can we increase the dual antiplatelet therapy also in some patients, therefore providing benefit for preventing future MIs. And what therefore transpired is that there are certain patients that dual antiplatelet therapy can be increased up to a year and a half to 2.5 years, and you can prevent remote MIs. MIs happening from other blockages. On the other hand, you have elderlies, you have patients with increased bleeding risk, where you have to shorten dual antiplatelet therapy so that you decrease their bleeding risk. So therefore, that is why Dr. Manoria's question came. On one hand, there's evidence showing that DAPT prolonged can decrease remote MIs. On the other hand, you can actually decrease also dual antiplatelet therapy, not from 1 year to 6 months, even to 3 months, and decrease the bleeding risk. So the balance has come. Those with high bleeding risks require shorter duration of dual antiplatelet therapy, maybe up to 6 months in ACS, which was always considered at 12 months. Acute MI, ACS, always considered at 12 months. You have a 78-year-old MI, you can actually decrease his dual antiplatelet therapy to 6 months. For a stable coronary artery disease, high bleeding risk, 85-year-old who's also got anemia, who has shown to have iron deficiency anemia, you can, and has a polyp or has an ulcer, which has suddenly bled, you can decrease it to 1 month in stable coronary artery disease. Minimum in stable coronary artery disease, unstable coronary artery disease, up to 3 months. But if you have a young guy who's 48, who's 55, who's actually got multiple vessel disease already. He's got atherosclerosis everywhere. You've treated 3 stents in the most important lesions, but he's got 4 other 50 and 70% lesions. I would prolong the dual antiplatelet therapy to 2.5 to 3 years, and maybe even longer, because I would be able to prevent his remote MIs. So we have now a precise TAP score, and we have a Hasbled score. For every patient, we put a precise TAP score, which tells us his thrombotic risk, and we put a Hasbled score, which tells us his bleeding risk, and we balance it out for every patient that we treat. And the dual antiplatelet therapy after angioplasty can be anywhere as short as 1 month for stable coronary artery disease, 3 months for 3 to 6 months for ACS, and for stable coronary artery disease in low bleeding risk can go, indefinitely, but at least for 3 years.
Young MI are not uncommon in India, and in young MI, it is the thrombotic factor which predominates or the atherosclerotic, and what can be done to minimize the recurrence in young MI?
Dr. Manoria, a very apt question at a time frame when this has actually been, the talk of the country, especially with recent incidents which have happened to celebrities who've had MI, who've had sudden death at a young age. While I don't refer to them, I'm just saying that it has become an important point of discussion for information, for understanding, for knowledge. Young MIs usually, and especially smokers, can develop acute MIs, which are mainly thrombotic, on even less than significant plaques. So for people's understanding, normally you've heard the situation saying, 70-75% blockage, we need to treat that because that's severe. You would be all surprised, and perhaps not surprised to know, that most of the infarctions actually occur from less than the 75% blockages. So the whole paradox is this, that the interventional cardiologists keep telling you, ye to artery 80% ki hogi, hame stent dalna hai, and yet the infarctions are occurring from 50 and 40 and 60% stenosis. That's plaque rupture. Those are soft plaques. And those who are smokers, or occasionally on severe, unaccustomed exercise, a plaque rupture can occur. And then a prothrombotic state forms. And the prothrombotic state can be due to many reasons. That's why in COVID, you had an increased spate of myocardial infarctions in young individuals. The prothrombotic state can be due to smoking. The prothrombotic state can be due to homocystinemia. It can be due to severe, unaccustomed exercise. That leads to platelet aggregation, clot formation, plaque ruptures, which is only a 40% stenosis. The major part is the thrombus. It closes the artery, and that is why young people get massive infarctions, because they have no collaterals. They haven't had time for collaterals to develop. So an 80 and 90% lesion in an elderly or 65 or a 75-year-old may cause less severe infarction, because that's chronic stenosis, which has given heart the time to develop collaterals, and that the young person of 35, 30-year-old who suddenly, because of heavy smoking or unaccustomed exercise, thrombosis with coronary artery, will actually have a massive infarction. And by the way, I talk about 40%. Smokers, drug abusers can get an infarction on a normal artery and close up a normal artery with a massive infarction. So we have to understand the whole pathophysiology and deal with it accordingly, which is the most important factor.
The other issue is that the combo of atrial fibrillation in ACS is not uncommon. And the usual recommendation is a brief period of triple therapy and then one antiplatelet and an oral anticoagulant. But after 1 year, all guidelines recommend NOAC. But what is the basis of this recommendation? And suppose you have a patient who has undergone left main stenting, multivessel disease, multiple stenting in a diabetic patient, will you not like to add an antiplatelet agent to a NOAC?
So again, I would want to put it into practical. I actually see the worst misuse of DAPT happening within a clinical scenario. And therefore, I think part of it is to be blamed on the drug companies, part of it is to be blamed on combinations, which have a statin and aspirin and clopidogrel all bundled together as a single antiplatelet. Stable coronary artery disease, by the way, never requires DAPT. I think I want to emphasize that. I'm not talking about stent implantation, I'm talking about stable coronary artery disease. And I would therefore urge you to understand that the maximum bleeding that we see, be it GI or be it intracranial bleed, in any person beyond the age of 65 and related to trauma is DAPT. So remember that DAPT is only a therapy for ACS for a duration up to 1 year, and for stent implantation thereafter, and for people who have stent implantations. Now, getting to the question of Dr. Manoria about, Dr. Manoria, the question was related to
ACS plus
yeah,
stenting done, ACS, AFib, and stenting done.
Correct.
After
And now
all guidelines recommend no.
That's right. So we must remember that AFib requiring anticoagulation is a disease of the elderly based on CHA2DS2 score. And yes, once we put a stent implantation, the good part is that the third generation stents are robust and least thrombogenic if implanted in an optimal manner. And by the way, what we say in an optimal manner is that we now are greater proponents, while at the time we've implanted a stent, to look inside the coronary artery through imaging devices that we have called intravascular ultrasound and OCT, which tells us that the stent has been implanted properly. So that's the first thing we would do in a patient who has AF and who we know has to be on limited antiplatelet therapy. We would optimize it, we would implant properly, we would put the least number of stents so that his ischemic risk goes down. Then in a month's time, we're obligated, by the way, latest guidelines say 2 weeks. Still, aspirin is needed. So depending upon the bleeding risk of the patient, he would be on triple therapy, which is anticoagulation, be it NOACs or be it warfarin, aspirin and clopidogrel at the time of discharge from the hospital after stent implantation. But if we got single stent and we've implanted it well, we would be able to withdraw aspirin therapy within 2 weeks. If you've implanted multiple stents, I would still continue aspirin therapy for 4 weeks. But by 4 weeks, this patient is going to be on a double therapy, an anticoagulation and clopidogrel. However, if the patient had a left vein and multivessel stent, if the patient was at very high ischemic risk, if the patient was at low bleeding risk and still had to have anticoagulation, I would extend the triple antiplatelet therapy by a month more, and if by another month. So at 3 months, I would definitely withdraw it for extreme ischemic risk patients. But for moderate ischemic risk patients, triple therapy would be 2 to 4 weeks. After that, clopidogrel and anticoagulation. Now comes the question, what do we do at 1 year? Having done this at 1 year, it is very clear. If the patient has tolerated aspirin at a low dose or clopidogrel at a low dose, has had no bleeding risk at all, has had left main plus triple vessel disease, falls into a impaired renal function, and is therefore continues to be at a high risk, I would continue it for 6 months more, a year more, and then withdraw the antiplatelet therapy completely and put him on oral anticoagulation therapy alone. So yes, you're right about the guidelines, but the guidelines have to be balanced against the patient in front of you. And by the way, bleeding risk and thrombotic risk, as pointed out by Dr. Manoria, is not a one-time assessment. A patient today who I think is a high ischemic risk because I've implanted left vein and another 2 stents, at 3 months become a low ischemic risk because the maximum time of stent thrombosis or having a heart attack with those stents was in the first 1 month. Then he starts getting low ischemic risk. At 6 months, he's even low ischemic risk. And if I see that he's an 80-year-old, I see now that he's a bleeding risk patient than an ischemic risk patient. And therefore, I tailor down his therapy. So it's a very expert evaluation. Therefore, we have now tailored antiplatelet therapy. But in general, if I was to tell you the guidelines, at 1 month, get down to dual antiplatelet, single antiplatelet and anticoagulation. At 1 year, you can actually get onto anticoagulation and no antiplatelet therapy in a routine non-ACS PCI patient. And also in an ACS patient.
Yeah. In patients of high bleeding risk, major bleed may occur. And under such circumstances, it is seen that when blood transfusion is given, it may be associated with increased mortality and morbidity. So what is your strategy for giving blood transfusion in patients of high bleeding risk who have developed a major bleed and have drop in their hemoglobin? When do you ask for a blood transfusion or you avoid it?
No, I do not avoid it. Blood transfusion in case of massive bleeding is the only treatment that the patient can have to actually to improve him. Therefore, you know what? It is blood transfusion. Bleeding requiring blood transfusion is an indicator of a heavy bleed and therefore is a poor prognostic indicator. It is not the blood transfusion per se, but it is the fact that it is such a massive bleed which requires blood transfusion. So we have nothing against blood transfusion. It just represents such a bleed that it can be detrimental to the patient, and we've got to manage the bleed as it is. The biggest challenge is, and again, it falls on all the physicians, therefore I want to tailor it to the physicians. The biggest challenge is when a bleeding happens to withdraw both antiplatelet therapy. Actually, it's a stepwise withdrawal of antiplatelet therapy. Of course, if it's a massive bleed and the GI, he's vomiting blood or he's got such severe melena, at that stage, you actually have to stop the DAPT. And then after stopping DAPT, momentarily, you have to try and treat the source of the bleeding properly, which means that if it was an ulcer, it has to be actually cauterized, ligated. If it's a lower GI bleed, the source has to be stopped so that reintroduction of at least single antiplatelet can happen as soon as possible. Because you cannot withdraw DAPT for greater than 4 to 5 days. Otherwise, it will lead to stent thrombosis, certainly in the initial few months. And it would lead to stent thrombosis forever. I mean, they are reliant on single antiplatelet for practically their life. I've seen stent thrombosis happen after withdrawal of even a single antiplatelet at 3 years for a GI surgery. So you have to be careful about that. And certainly, for small bleeds like epistaxis, for going for a dental procedures, for going for cataract surgeries, it's all that is required is a single antiplatelet therapy, never a withdrawal of total antiplatelet therapy, because that can be dangerous for the patients in terms of stent thrombosis happening, peaking at 3 to 5 days after single antiplatelet therapy, even withdrawal in patients who've got a drug-eluting stents. I want to therefore emphasize that very important aspect.
Which de-escalation therapy you would prefer? Aspirin plus ticagrelor for 3 months, followed by ticagrelor alone as shown in the two light and the TICO, or aspirin plus ticagrelor for 1 month, followed by aspirin plus chlorprotocol thereafter, as shown by the topic card.
Yeah, that's a wonderful question. That's a wonderful question. I'll tell you, I prefer the twilight regime. And I, again, for the physicians, want to address what Dr. Manoria has asked. See, the trial of twilight is that you start off with aspirin and ticagrelor in patients and you balance out the risks. Therefore, you're looking at the net outcome. There are patients with ischemic risk and the patients with bleeding risk in that study. And then at 3 months, after 1 month, the patients were randomized. At 3 months, aspirin was withdrawn, so the patient only remained on ticagrelor. And what was seen was that over the next 12-month period, that the net benefit was more than if one continued both agents for 1 year, which means the net benefit of low bleeding risk and low ischemic risk was in favor of single antiplatelet. For the first time, we saw a situation where single antiplatelet can actually do good very early on. The second option Dr. Manoria is saying is there are trials which show that you can actually get rid of ticagrelor, which is a very potent antiplatelet agent, and replace that with clopidogrel, which is a less potent antiplatelet agent. So aspirin plus ticagrelor in the first month, when the maximum ischemic risk and thrombosis happens for the stents, and then replace it with a lesser regime. So my preference is, Dr. Manoria, to the twilight regime. To continue ticagrelor subsequently. I'll tell you why. The problem of clopidogrel at the moment for us in India is that we are not sure of the clopidogrel resistance, or call it the allele, presence of the allele, which creates the clopidogrel intolerance. Basically, what I'm saying is that ineffectiveness of clopidogrel may occur in 25 to 30% of the patients where it's not clinically effective. So when we actually discontinue or put patients on a single antiplatelet, and there are Korean studies which have done single antiplatelet after the first month and continued that for 12 months, the Japanese study, they all relied on clopidogrel. We can't rely on clopidogrel, and therefore we prefer certainly even in our ACS patients, in our complex patients, in our triple vessel disease, in our bifurcation stenting, not to just rely on aspirin plus clopidogrel so early on, but certainly can be relied on ticagrelor, because there is no resistance to ticagrelor. It's a new P2 inhibitor without any resistance So we are comfortable with using ticagrelor alone because of its predictable action in our complex patients.
With image-guided angioplasty being increasingly done, better and better stents, better drugs, will a day come when only single antiplatelet agent will be used after a PCI?
A very important question. I don't think a day will come right from the first day that a single antiplatelet agent can be used. And I say that primarily because of the fact that despite image guidance, say, even in the studies of atrial fibrillation and anticoagulation in triple regime, even in the studies of triple regime, the reason ecosprin still didn't go out is because in the study of apixaban, it is clearly seen that there was a greater incidence of stent thrombosis in whom aspirin was discontinued as early on as 1 week. And that is why that remains of aspirin continued for 4 weeks, even though the recommendations came for 2 weeks. It still says that for those with high ischemic risk, better to use aspirin for 4 weeks because of the increased thrombosis which was seen in the group without aspirin, in whom aspirin was discontinued as early as 1 week, even though clopidogrel was on and even though anticoagulation was on. Therefore, it brings to my point that we can decrease perhaps to 2 weeks in most stable cases with optimization, but it'll never happen in ACS. I think in ACS, we're very clear, these are high-risk patients and will constantly need dual antiplatelet therapy unless a patient bled right soon after a procedure, had massive bleeding, had an intracranial bleed, or for some reason had to actually have a discontinuation. We would never get aspirin early. We will get aspirin off after 1 month is a reality. It can happen after 2 weeks, but never at the time of the procedure.
We do not have any antidote to antiplatelet agents. The reversal agent for ticagrelor is being developed. What is the current status?
Yeah, the current status is pretty difficult. The current status is withdrawn, but the good part of ticagrelor is that it is very short acting. And that is why the concern that while it's a BD dose, we even say to everybody that don't even miss a single dose of ticagrelor, because it actually starts vanishing from the body in 12 to 48 to 24 hours. And that is why even I want to emphasize to all our listeners that when we subject our patients to surgery on dual antiplatelet therapy, ticagrelor is not a concern to our surgeons, because even 24 hours is good enough for a washout, though the recommendations are 48 hours. For clopidogrel, it's 5 days. For surgery, for prasugrel, it's 7 days. But the official recommendations for ticagrelor only 24 hours. So at the moment, it is not of such a concern, because you withdraw ticagrelor, you give blood factors, you give platelet factors, you give platelets, you give blood constituents, and that is good enough for the time being to tackle the bleed. And I think that's at the moment. But I think antidotes will take their own times, but I don't think it's such an issue in our lives at the moment.
Is prasugrel an unsung hero? Your comments?
Yes, prasugrel is a very potent agent. I believe even more potent than ticagrelor, because that is what has been demonstrated in trials. That randomized trial of ticagrelor versus prasugrel demonstrated in favor of prasugrel for stent thrombosis. Now, therefore, it became a class 2B recommendation in the latest European Society guidelines. First, but then there are certain important factors to understand. Being a potent antiplatelet and being a very long agent also has advantages and drawbacks. For example, age over 75, high bleeding risk. Weight less than 55, high bleeding risk. The prasugrel creates high bleeding risk. Surgery can't be done if a patient is a prasugrel, yet it can be done on ticagrelor. Therefore, prasugrel has ever been shown to be beneficial in ACS. When I say ACS, unstable angina, non-STEMI, it's only been shown to be beneficial in after stent implantation in ACS and STEMI. So it is not a standalone agent. It is an agent to be still used in the cath lab when you see an angio that in an ACS or a primary PCI, you see a patient whom stent can be implanted. And if it's a stent, you can put a patient on prasugrel. But if it's not a stent, and if it's a surgery, it'd be a disaster if the patient's been treated by prasugrel, because he would bleed heavily at the time of surgery, and therefore the surgeon may not touch him for the next 4 or 5 days. So yes, prasugrel is an unsung hero, in great drug when you have complications, great drug when you have stent thrombosis, tremendous agent for extremely complex angioplasties in low bleeding risk patients, superior in a single trial to ticagrelor, but there's only a single randomized trial. But on the other hand, it has a number of drawbacks which impedes its routine use in our intervention practice.
PCSK9, as you said, on top of statin and ezetimibe, are very useful in high-risk ACS patients. But the issue is how long they should be continuous. What do you follow in your practice? How long?
So I actually, for the young patients, in fact, for every patient till now, I've continued it on and on and on, because these are the patients who actually have had repeat events, who've already had events, whose in fact the LDL cholesterols should have been at 40, should have been at 40. And after the recommendations of 40 and 30s come, I actually have them on, and I continue to have them on, and I won't take them off. Now, when would it till be? I think more data will be coming, more understanding would be coming, but I want to keep those LDL cholesterols at 30s and 40s. And by the way, they are not standalone agents. They are given with rosuvastatin and ezetimibe to get their levels to 40, because if you withdraw rosuvastatin and ezetimibe at 40 as well as 10, the LDL cholesterols could actually not be as low as they're being demonstrated. So yes, remember these agents as not standalone agents. They have to be on the maximum tolerated dose of statins with ezetimibe. Evolocumab is add-on, and we actually therefore would continue to treat patients on this for the longest period of time. And usually I think I've tested all doses out. For me, it comes to twice a month is necessary in most patients. Otherwise, you actually, by 3 weeks, start seeing their LDL cholesterols rise to 70s and 80s.
If an asymptomatic individual has an LPA 80 on top of statins and ezetimibe, will you like to use PCSK9 inhibitors before the acute event occurs, or they are only used after an acute event?
Yeah, not at the moment, not at the moment. If LDL cholesterol target has been achieved, I'm not chasing LPAs. I know that there are a marker for coronary artery disease, but the patient already in front of me has manifest coronary artery disease. So for me, chasing LPA alone is absolutely not evidence-based at this time. Now, remember, we don't know the long-term effects of the agent. We don't know whether it's actually going to decrease events in those who have LPA raised alone. We know that it decreases events in those with LDL cholesterols, which are high. So we have to wait for evidence-based science and outcome data before we actually start applying these drugs to our patient on a long-term basis. And the outcome data has not got to be short-term, has got to be intermediate term, and has to go on to longer and longer-term follow-up. So if we have an evidence of 3 to 5 years, I would say that's good enough to us start using the drug, but we need evidences of 10 years to say we're doing the right thing for the right patient in the longest term, because we got to, once put on these drugs, we've got to continue to use them forever. That is the comfort we have with the statins at the moment, because they are drugs which have been used for the last more than 25 to 30 years, right from the days of simvastatin. And therefore, we know what to expect from them in terms of risk versus benefit analysis. And that's why I do use them very, very regularly. It's like I said, stated right in the beginning, I have to achieve those targets, but we will want more data for areas which haven't been related to outcomes at the moment.
So the last question, a young patient of STEMI undergoes PCI and his brother wants to know what is his risk of developing acute myocardial infarction in future? How do you address this issue to the relatives?
So young patient has been diagnosed to be coronary artery disease. Is that what you said? And people want to know, his relatives want to know whether he'll develop an MI? Well, I think very importantly, let's emphasize again in the present era, prevention, 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 and secondary prevention becomes paramount in our sphere. Primary prevention becomes paramount in our sphere. And therefore, for me, I would actually tell him that if he really did the right things, his chances of coronary artery disease are extremely low, which means, as far as I'm concerned, making sure that he doesn't smoke, making sure that he daily exercises and gets to 200 minutes of exercise of brisk walking a week, making sure that his weight is ideal, making sure that his LDL cholesterol is brought down by statins, especially if it had a high CRP, and making sure his LDL cholesterol is down to approximately 50s. And I'm saying that with only atherosclerosis and no coronary artery disease, I would bring it down to 50s and 40s in a young guy like that. Making sure that he actually had hypertension and diabetes if he had that under control. Making sure that he never gets near to a smoker, doesn't even become a friend of a smoker. And if he followed that, but actually lives a normal life, exercises and eats, by the way, nobody needs to have extreme inhibitions about eating. We just need to know the right food. Ghar ka khana. Ghar ka khana is the best form of diet that can be created. And if he does that, believe you me, his chances of getting an MI are extremely low. The problem is that is what we don't do. We don't do the proper primary prevention. And I think that's where we lack.
I'm sure all of us enjoyed the flashes of expertise of Dr. Seth. So the session is now open for questions and comments. If there are any questions from the faculties or from the chat box. Dr. Pandey, you wanted to ask something? Dr. Abhay Pandey? So if there are none,
there is one question, Dr. Manoria.
Okay, please. Yes,
Yeah.
Dr. Yolekar.
Yeah. Dr. Seth, you have been very articulate in pointing out the dangers of abrupt cessation of DAPT.
Yes.
I very much appreciate that. But you have focused exclusively on LDL. In Indians in particular, what about LPA? What importance do you give and when?
To the LPA?
Yeah, yes.
By the way, I know that it can be, firstly, very clearly, it's a marker, and secondly, it's a causative factor also. That both are very clear. What is still not clear, at least to me, unless you can update me, is whether any treatment of LPA has been linked to improving outcomes, just like it has for LDL. So I know that is the reason until now, because outcome data over a long period of time, using using drugs like Repatha, which can actually lower LP, are not there, and the studies are going on, by the way, when those studies demonstrate that LPA is an important factor, treating of which will alter outcomes in our patients, we'll do that. Till that time, my first target is LDL. My second target is triglycerides is above 500. My third target is HDL, if it can be increased by exercise. And I would, in low HDL cholesterol, I would use rosuvastatin rather than atorvastatin, because rosuvastatin can cause an increase in HDL cholesterol to the tune of 2 to 3%, while atorvastatin drops it by minus 9%.
That's fine.
So with this, we end this session. Thank you very much, Dr. Seth, for the wonderful comments. We pass on to the next session. Bye-bye.
Thank you. Thank you. Thank you, Dr. Manoria. Always a pleasure talking to you and having this conversation. I enjoy it thoroughly, and I would love to be with you many times.
Thank you very much. We move on to the next session, and the next session is on a very interesting topic: thrombocardiology, emerging concepts, emerging therapies. And the speaker for this session is no other person but Dr. Tiny Nair. Dr. Tiny Nair is our dear and near friend. He is head department of cardiology, PRS Hospital, Trivandrum, Kerala. He has received several awards: Best Doctor Award, Government of Kerala 2006, Most Inspiring Doctor of India, Economic Times 2019, Best Reviewer Annals of Internal Medicine 2019, on the editorial board of several journals like Hypertension Journal, IHJ, KHJ, and European Journal of Heart Failure. He's the author of 4 books, the latest being Magic of India Medicine, and he has 45 publications, 4 national orations, and a top writer, Quora blog, and talk speaker. The chairpersons for this session are Dr. Abhay Pandey, Dr. Balbir Kalra, Dr. Aziz Khan, Dr. Spandan Badri. I'll hand over the mic to Dr. Abhay Pandey to conduct this session. Dr. Pandey, please. Dr. Pandey, is he not there?
Yeah, I'm there. The field, good evening, everybody. The field of thrombocardiology deals with the delicate balance between the thrombotic complications and bleeding. It is very important for modern cardiology, as dramatic thromboembolic complications such as myocardial infarction, stroke have stimulated development of many drugs which predispose to the serious bleeding. Dr. Tiny Nair will deal on this important topic of thrombocardiology, which gives us a balance between bleeding complications versus thrombotic complications of the newer drugs and antiplatelet agents. Dr. Tiny Nair, please.
Thank you, sir. And thank you, Dr. Manoria, for inviting me to your beautiful sessions. Every time I thank you, and I love to attend your sessions. Give me a moment's time by the time I share my screen. Sharing. Can you allow me sharing, please?
Yes, yes, please.
Yeah, thank you. Thank you. Thanks. That's right. Can you see my screen and am I audible?
Yeah.
Thank you. The concept of thrombocardiology, the term is kind of new, came in 2009 when this beautiful editorial was written by Professor Eugene Braunwald, highlighting thrombocardiology. That was a time when the NOACs had just come into the market, and he was talking about exactly the thing that our chairperson just highlighted, that how the delicate balance of bleeding and thrombosis could be changed by these new drugs. Theodore Roosevelt had once said that, I believe, that more you know about the past, the better are you prepared for the future. So for a topic like where I'm supposed to talk about the future, I think we need to delve into the past to know about the future better. Now, that is 80 years back, August 20, 1936, when a very unusual publication came out in which Dr. W.e.f. reported something very unusual. He said that he found that the platelet count in pulmonary veins were more than in pulmonary arteries. Now, just imagine what he said. He said the platelet count in pulmonary vein is more than that in the pulmonary artery. So what exactly did he mean? He said that he meant that his concept was that there's production of blood platelet in the lungs. Funny, interesting. We all know that platelets come from megakaryocytes, the bone marrow, and here is somebody in 1936 who said that the platelet might be coming from lungs. You know, for the next about 70 years, the whole concept was under wrap and everybody knew that this is wrong, till about a year back, when we started seeing slides like this. This is an electron microscope slide of the lungs. And as you can see those red dots there, what are those red dots? Those red dots are nothing but stained megakaryocytes. And if you enlarge them, you see those green tangled masses between those alveolar septum, which are nothing but megakaryocytes. Today, we very clearly know that yes, megakaryocytes are manufactured in the lungs also. Okay, so if we look into the newer publications, we see that, for example, there is one article which talks about lung megakaryocyte displays distinct transcriptional and phenotypic properties. Okay, this is another one which talks about lung megakaryocytes are immune modulatory cells. Now these ones, as you can see, there are 2021 publications, and obviously in the last 2 years, such publications became very much popular and more important because we knew lung became the focus in this pandemic of COVID-19. So first thing first, yes, lung does manufacture megakaryocytes which produce platelets. So there's a subset of platelets that comes from our lungs and not just the platelet, and they look like that. You can see that's a CD41 stained platelet. The megakaryocyte that is producing platelets lie right in the pulmonary interstitium. Now, this is one of the, I think, if we spend some time on COVID thrombosis, one of the best articles is the one that came in JACC from Valentine Fuster's group. That study was done in Mount Sinai, New York. The pathology and of course the anticoagulation, bleeding mortality in the background of COVID-19. In fact, this article gives very beautiful post-mortem slides, which are very interesting. For example, you see that is a thrombus right there in the pulmonary artery. You can see there's a large thrombus in the pulmonary vascular tree, and that is another one that is in the cerebral vessel. That you can see that partially clot-filled artery in one of the small vessels branches in the brain. And of course, you can see that is a clot in one of the myocardial arteries. So you see pulmonary artery clot, you can see cerebral artery clot, you can see myocardial clot, all in the background of COVID-19. And of course, these are pathological specimens, pictures shown in the JACC in the same article, where you see multiple thrombotic lesions in very many areas of the brain in autopsy studies in the background of COVID. We know that COVID gives rise to multiple thrombotic occlusions. And that one, funny enough, is a clot in the portal vein. So, you know, no area is spared. Whether you are looking at the venous system or you are looking at the arterial system, you see that there are clots everywhere in the background of COVID-19. Now, this is a concept that came in one of the new Lancet articles that came about a couple of months back, where they said, yes, if we look into the blood vessels close to the bone marrow, right, that light blue is bone marrow, you see the blue megakaryocyte producing platelets that they just kind of squeeze through the endothelium and come into the vascular tray. So the megakaryocyte actually remains outside the vascular tray, but tucked on very closely to the endothelium, producing small offsprings, those platelets that come into the vascular system and they pour into the vascular system from the bone marrow. But in contrast, that is the megakaryocyte. So you can see megakaryocyte BM, so bone marrow derived megakaryocyte. In contrast, if you look at the lungs, okay, the megakaryocyte precursor in the lungs, that is what it remains in the lung interstitium. But in the case of the lungs, the entire megakaryocyte goes into the pulmonary vascular tree. The entire megakaryocyte. So unlike the bone marrow, it doesn't produce platelets that go around. So this kind of mature megakaryocyte squeezes out from into the vascular tree, and right at bifurcation produces platelets. So the point is, these platelets which are shown in yellow are different from the platelets that are blue, both morphologically and immunologically. And it is this yellow colored platelet that you see on the right cartoon, which are responsible for the thrombotic events in viral infections like COVID-19, and that is the concept. Now, this study, the article in Lancet also points out that, for example, you see that is a CT scan of pulmonary thrombus, right? Pulmonary thrombus, we can explain, forms in the vein in the leg and might have gone from a DVT or somewhere in the venous system. But in contrast, they also show, for example, the Doppler of the subclavian artery. Subclavian artery. And you see that echo-free space, that is a thrombus. That is a CT scan of a thrombus in the abdominal aorta. So the point is, how come there are clots in the vascular system like aorta as well as the venous system? Venous, you can say, okay, stasis, we know that stasis causes thrombus and the thrombus comes in. So that could not be explained till we knew this point. So all these years we were talking about what they now call as a second mechanism. Deep vein thrombus or a venous system thrombus because of stagnation, because patient is in rest, just like our DVT. That goes to the right atrium, right ventricle, and goes to the lungs. But that then goes to go to the lungs. That does not explain how clots go to the brain. In COVID, it doesn't explain how clot goes to the kidney. In COVID, doesn't explain how by microscopy of the skin you can see multiple small emboli in the skin. And to explain that, you need to know that megakaryocytes come from the lungs. Yeah, so what was said by Howell 8 years back is true. From the lungs, you get those megakaryocytes that slowly percolate down through the pulmonary vein into the left atrium, left ventricle, and go to the entire systemic circuit. Not just that, the same Lancet article, very interestingly, shows that if you look at the venous production of platelets, and you see those two kinds of platelets, on the left you see the immunothrombotic plot, meaning that the platelet that is originated from the lungs, they are structurally different from the clots that are generally formed in the vascular system, which we know of. So today we are talking about platelets coming from lungs, which is an absolutely new development and understanding in thrombocardiology, where we're trying to target these kind of platelets, not just platelets as general, not just anticoagulant pathways as general, but these ones which create problems for us. So from that understanding, let us leave COVID behind and go to general thrombocardiology. We know about the players in thrombosis. We have the platelets, we have the coagulation factors, and we have the endothelium. And of course, stagnation plays a role. So many sepsis plays a role. But the basic players are platelets, coagulation factors, and endothelium. And that's why we know that when we target them, we have options of antiplatelets, we have low molecular weight heparin, we have plain heparin, we have VKA, vitamin K antagonists like warfarin, and we have the NOACs. Okay, we have all the antithrombotic options for treating our patients. We are not talking about COVID anymore, we are talking about general thrombocardiology. Now, the point is, this is something which I think is very vital to understand, to look into what we are now trying to develop in the next maybe 10 years' time. For example, if you look at the trials whereby we graduated from aspirin to aspirin plus clopidogrel, aspirin plus ticagrelor, and as time passed, every trial showed that the ischemic thrombotic risk had come down. Yes. But every time when we added a new antiplatelet or a new anticoagulant for that matters, we see that the risk of fatal and non-fatal bleeding progressively went up to a tune where triple therapy, just now you heard about triple therapy has gone to 4.05 hazard ratio. So every new antiplatelet, more potent, new ones we add, every dual antiplatelet, triple antiplatelet, every new anticoagulant we add, yes, we prevent ischemic event, but we also increase the risk of bleeding. So you might say, okay, just the risk of bleeding, if there is no bleeding, how does it matter? Despite the fact that we are not sure how, but today we know that if we are looking at bleeding, for example, we are looking at 30-day mortality, and we are looking at the graphs, on the left is no bleeding, mild, moderate, and severe bleeding. We see that 30 days, the gusto bleeding, we clearly correlate with significantly high mortality. To what extent? 25%, right? So it is more perhaps than the ischemic event itself. In contrast, even if you look at 6-month mortality, still the mortality is very high, which means it is not just that one single event of bleeding, but generally bleeding adds up hugely to event rate post any antiplatelet, any anticoagulant. So the effort in the last couple of years and the next 5 or 10 years is to separate the risk of bleeding, reduce the risk of bleeding, maintaining the risk of anti-thrombotic, anti-ischemic benefits. And the first step of that actually to the ground level came when we realized that, okay, we were looking at platelets, developing aspirin, clopidogrel, ticagrelor, newer and newer antiplatelet, but we were forgetting that to get a sufficient anti-ischemic background, there's a large element of clotting factors left there. So if we use a very low dose of anti-clotting medications, piggybacked onto our antiplatelet therapy, we probably can reduce ischemic events at the same time, not increase the risk because we are targeting with a low dose of antiplatelets and a low dose of anti-thrombotic agents. And with that concept in mind came the COMPASS trial, which we are always aware about COMPASS trial. We have discussed it very many times, not spent time, where rivaroxaban in stable cardiovascular disease we are taken up, where patients of CAD, PAD, CAD plus PAD, are those that is basically multivessel disease, polyvascular disease, or patients of CAD who were less than 65, had to have 2 vascular beds or 2 additional risk factors. We are aware about what happened. We very clearly saw that compared to aspirin alone or rivaroxaban alone, rivaroxaban small dose, 2.5 milligram BID plus aspirin proved to be much superior, returning hazard ratio of 0.67, about 24% reduction of MACE and event rate, which looked like fantastic. But I think when we are talking about thrombocardiology, and like our chairperson said, talking about bleeding, the concept of DPI, the first thing that strikes us is bleeding. Yes, even in COMPASS trial, bleeding did increase. And we very clearly saw that major bleeds were more. And the hazard ratio of major bleeds was 1.7, significant. But hold on, what was promising was when we looked at fatal bleed with intracranial hemorrhage and symptomatic bleed in critical organ, I mean things that would kill, fatal bleed, intracranial hemorrhage, symptomatic bleed in critical organ, we saw that there was no difference. It means yes, the concept of low dose anticoagulation with antiplatelets, we did see benefit. We did see increase in bleeding, but those bleedings were not fatal, no intracranial hemorrhage or no symptomatic bleeding critical organ taken together, it was same. So we started looking at net clinical benefit. That means ischemic events prevented and bleeding increased, but what is our net benefit? We saw that MACE plus fatal bleed, symptomatic bleed in critical organ, the hazard ratio is 0.80, means 20% reduction, again p-value significant. Now, I think looking into that aspect came the COMPASS trials clinical efficacy data that came in JAMA, again by Eichelboom. We have discussed with Dr. Eichelboom so very often in Zoom forums about this particular benefit, and this is how it looks. I think this is a very important chart, which we should spend a minute. In this chart in COMPASS data, whatever we see there on the x-axis is timeline. The first graph is 12 months, second 24 months, and third bar is 30 months. And that baseline 0, anything below is increase in bleeding. Anything above is reduction of event. So anything below increase in bleed in red, anything above reduction of events. And blue is cardiovascular death, light blue is stroke, very light blue is myocardial infarction. And of course, red is symptomatic bleed into critical organ or fatal bleed. Now, if we see the first bar, the event rate reduction is at 6, which moves up to 16 at 24 months, and the benefit moves up to 24 per 1,000 patients treated at the end of 30 months. So a big jump for events prevented per 1,000 patients. Okay, from 6 to 16 to 25. In contrast, when we look at bleeding, it was kind of 2, 2, 2, or 3. So it was kind of similar. So over time, in COMPASS data, we saw that the bleeding remained same, but efficacy increased. So it was almost like what exactly we wanted. So we wanted that there should not be increase in fatal bleed, there should not be increase in major intracranial hemorrhage, critical organ bleed, and over time, efficacy increase, bleeding does not increase. This had not happened before this in any clinical trial, where over time bleeding did not increase and efficacy increased. So we were happy that we are reaching almost what we wanted. But understand that the problem was still there. And that is where the second article 2018 came up, where they again talked about thrombocardiology, COMPASS to reach registry, the new are patients on the right with thrombocardiology benefits, risk and future of the new concept. But let us move forward and see what is in store for future for us. A very interesting article that came in ATVB, Novel Antiplatelet Therapies and Atherothrombotic Disease. Now, in the region of platelets, if we take the platelet right in front of us, we know that we have very many mechanisms to pacify platelets. For example, aspirin, we can use GP2V3 blockers like abciximab, trofinetide, eptifibatide. We can use P2Y12 inhibitors, ticlopidine, clopidogrel, prasugrel, ticagrelor, and cangrelor intravenous. We can use PAR1 and PAR4 protease activator receptor blockers like vorapaxar. Okay, so we have the huge list of antiplatelets which we have with us to treat in the basket now. So these are all the lists of available antiplatelet agents. In fact, we have today a wide variety of agents. For example, look at cangrelor, right? With the 30 micrograms of IV bolus followed by 4 micrograms per kg per minute of infusion, we have a what? Half-life of 3 to 5 minutes. So it is purely under our control. The moment we stop the infusion or the drip, the antiplatelet effect goes away.
तो स्लाइड प्रोजेक्ट कर देंगे मैं हैंड ओवर
कैन यू प्लीज स्टॉप योर कैन यू प्लीज म्यूट
स्लाइड प्रोजेक्ट कर दूंगा तो देख के बोल देना और
सर कैन यू प्लीज म्यूट
टॉपिक का टॉक देख लो, वो निकाल के रखा है काय पे टॉक है प्रोग्राम का, लिख के रखो.
अरे सर कैन यू म्यूट प्लीज. So next we can, in contrast, we have vorapaxar, which has a half-life of 5 to 13 days, right? So we have two extremes, 3 to 5 minutes with cangrelor and a half-life of 5 to 13 days with vorapaxar. So what we're trying to say is that we have a huge basket available with us today, all kinds of antiplatelets. But, you know, these are the new antiplatelets that are coming. Two are very interesting. One is the GP1B95 inhibitor. This is the GP, the glycoprotein receptor that combines with the von Willebrand factor. And there you have the caplizumab, which is a promising agent. And of course, we have the GP6 blocker, the glycoprotein 6 blocker, what is called a Revacet, that is again undergoing trials. In fact, that is extremely interesting. And why it is interesting, we will spend a little bit of time. Those are the huge number of newer antiplatelets. They're going to come and change the face of thrombocardiology. But understand this. We are today trying to see, can we preserve hemostasis? Which means we are trying to say, as we use anticoagulants, there is a difference between thrombosis and hemostasis. Thrombosis is a clot which is pathologic, forming in the vascular system, while hemostasis is a physiological system that stops bleeding. So all these years, obviously, logically, we thought that whether we use an antiplatelet, whether we use an anticoagulant, there's no way, right? If we inhibit a platelet, it'll bleed more. Inhibit clotting factors, whatever, NOACs, vitamin K10, it'll bleed more. How can we stop that? But suddenly there is a change and a new concept. For example, if you look at the bottom part of that platelet cartoon, you see GP6, the glycoprotein 6 receptor, getting attached to the collagen. But that is not the usual collagen. That is the exposed pathological collagen. And that exposed pathological collagen occurs only when there is a pathological plaque rupture, right? In a normal cut or a normal breakage of an artery, you don't get pathological collagen. And only when there is a pathological collagen, the platelet attaches to the pathological collagen by glycoprotein 6 receptor, the green one that you see. Now, how important it is? This looks like eminently important, because if we can, which means theoretically, if we can block that GP6 receptor, we can prevent pathological attachment of the platelet to the collagen, damaged collagen, but the other platelets are fine. So hemostasis will continue to be normal. And that looks like a huge promise. For example, that's an editorial and an article that came atherosclerosis, thrombus, and vascular biology on glycoprotein 6 blockade, not just targeting collagen anymore, but targeting the pathologically bad collagen, preventing it from attaching on to the platelet, which they say it is like, apply a coating on the abnormal collagen so the platelet doesn't react with it. So for example, if you see a damaged collagen, there's extremely large amount of release of GP6. And if you see that GP6 itself fetches more platelets and a large thrombus forms. But GP6 has very little to do in a normal damaged endothelium. Right, so it's extremely interesting that a GP6 blockade is likely to prevent thrombosis, but has no effect on hemostasis. In fact, the first ever trial came out in March 2021, where they tried safety and efficacy of Revacep. Basically, it's a safety trial, which is the ISAR platelet, ISAR plaster trial. But they tried it in stable ischemic heart disease. They were given permission only to do this study on stable ischemic heart disease. And the ISAR plaster phase 2 trial, what did it show? It showed that there was no significant prevention of MI or thrombotic events, but there's no increase in bleeding at all. So placebo and Revacep, which blocks the GP6, showed there's no increase in bleeding. So it is safe. And now it did not show benefit because it was used in stable ischemic heart disease patients. Today, most experts in thrombocardiology opine that these concept of inhibiting the GP6 probably would give us benefit in acute coronary syndromes, in areas where the exposed pathological collagen is far more worse, and probably we have to wait for the results to come.
Dr. Tiny, please summarize.
Yeah. So that brings us to certain newer agents like targeted therapy for thrombolysis, echo-driven, magnetic field-driven, and ligand-driven. And we are trying to look not just at the platelet, but as neutrophils as well. So if we get an activated neutrophil, the neutrophil releases all those kinds of spring-like coils. What are they? They are neutrophil extracellular traps. In fact, those neutrophil extracellular traps are DNA particles that activate platelets and create a huge big problem for thrombosis. So finally, thrombosis is tangled today with nets or neutrophil extracellular traps. You can see that is a color image of how the extracellular DNA looks like. And that is an image where the greens are DNA and the red is von Willebrand factor. So finally, where are we with all this in thrombocardiology? We say that we presume and we believe that the future is good. the future is as bright as your faith, right? And we believe that in the next 10 years or so, we would see a tremendous jump forward in thrombocardiology, where we are seeing a dichotomy between thrombosis and hemostasis. Hemostasis would be still preserved, while thrombosis would be gone. At least we hope so. Thank you for your time and attention.
It was a great lecture, Dr. Nair. Congratulations. You have done a great job. Are there any scales or any pointers to like Hasbled score to predict the bleeding complications versus thrombotic complications in thrombocardiology now?
Not really, because as we all understand, all the scores, including Hasbled, and every score has been under tremendous scrutiny. And we very clearly say that Hasbled score is not one which you should use not to prescribe a NOAC or anticoagulants, but probably to estimate the amount of bleeding that a person can have. But I believe the very fact that we have so many thrombotic scores, right from Gusto to the international scoring, shows that perhaps none of the scores are perfect. And each trial, including TIMI and Gusto, and every score has its own vagaries, plus and minus.
Okay.
Dr. Nair, very good lecture, very thoughtful lecture. And as usual, always your lectures are very exciting. What do you see future of this low-dose rivaroxaban in future?
No, as far as I'm concerned, I think it's very exciting. In fact, we use a lot of low-dose rivaroxaban. I was just listening to Dr. Seth talking about the dual antiplatelet. So I strongly believe that, like he said, the twilight pathway, I very strongly believe that the compass pathway, we would have in future low-dose antiplatelet coupled with a low-dose rivaroxaban taking up as a long-term antiplatelet therapy. And I believe that would be much more safer, and that would give probably a much more reduction of ischemic events.
After 1 year of patient with after angioplasty or ACS, you have 2-3 ways to go. Whether the patient goes for Pegasus way or this compass way or Themistra way.
Whichever.
So what
they are trying to say that, see, I think again it is individual. If I see a patient who has a polyvascular disease, many often our friends ask that, what did you learn from compass? It is not a low-dose rivaroxaban. From compass, we have learned that apart from the LV function or the degree of coronary artery disease that we have, polyvascular disease has emerged as a risk factor. I mean, that is what I have learned from compass. So if we see a person with a peripheral vascular disease plus a cerebrovascular and a cardiovascular disease, he has tremendously high risk of event rate, including peripheral, male, and CVAs and CADs. And that, I believe, could be prevented only by if we target both the pathways, what we consider as a dual pathway inhibition.
One question, Dr. Tiny.
Yes, sir.
What is, according to you, is the weightage that can be given to hyperglycemic state and severe hyperlipidemic state in terms of prothrombotic contribution?
In fact, I had done a lecture for a couple of months back where we have very clearly shown that exactly, sir, like you said, both dyslipidemia and hyperglycemia by itself creates a prothrombotic phase, prothrombotic state, just because the sugars are elevated and just because the lipids are elevated. We are not talking about lipid producing atherosclerosis. We are not talking about the hyperglycemia producing micro or macrovascular disease, but just because of presence of blood sugar in the plasma, just because of presence of more of viscous lipids in the plasma, there is a general tendency for more thrombus to form. They again go through many pathways, and it is exactly like the browning of the bread that we talk about. HbA1c, for example, is glycation. So adverse glycation end products are nothing but just like a bread becomes brown and HbA1c increases. So same way, there is a prothrombotic state simply because the sugars are high or the lipids are high.
Dr. Tiny, 2 questions. Firstly, yes, the subset of patients which were included in the COMPASS trial, only 2 to 3% patient has stroke, and yet it has shown a dramatic reduction in stroke. So usually the COMPASS trial is projected as a treatment for those who have a polyvascular disease.
Yes, sir.
Personally, I feel it should also be projected for primary prevention of stroke because there's a dramatic and only 2 to 3% were stroke.
Correct.
So your
Not a
comment
secondary
is-
prevention, but a primary prevention of stroke. Exactly. In a background of polyvascular disease.
Yeah. Secondly, MI was not statistically significantly decreased. So do you think we should have some future strategies excluding aspirin, low dose rivaroxaban with either a clopidogrel or even a tetragrel if bleeding does not occur to test which is more appropriate for reduction in MI? After all, we also want reduction in MI besides stroke and peripheral vascular disease. The trial clearly shows MI were not statistically significant.
True, exactly. I fully agree with you. Because, for example, in the AFib trials, we have added clopidogrel to standard dose of rivaroxaban. So they are safe. Upon whether ticagrelor would show a similar benefit, we don't know. It might be actually better.
And how long will you continue DPI?
Oh, which one? DPI? Again, lifelong. Small dose would be lifelong.
So with this, we stop this session. Thank you very much, Dr. Tiny. We enjoyed the flashes of your expertise. Thank you very much. And we move on to the last session, will be a very brief presentation. The chairpersons for this session is Dr. S.K. Parashar. I'll hand over the session to Dr. Parashar. Dr. Singh and others could not join because of some emergencies.
Thank you very much, Dr. Manoria. This is the very important section of the talk that is under pharmacotherapy. The topic of Dr. Manoria will speak on the ACC 20121 consensus impacted treatment choices in the treatment of heart failure with reduced ejection fraction by Dr. PC Manoria. I will request him kindly deliver his talk on this topic. Thank you.
So for the next 10 to 12 minutes, I'll be talking on this topic, ACC 2021 consensus impacting treatment choices in HFrEF. The current estimates of heart failure in India vary widely from 1.3 to 23 million. And all of us know heart failure, once sets in, runs a malignant progression with a very high morbidity and mortality. The 5-year mortality is to the tune of 50%. Drugs and device therapy no doubt blunt this progression and increases longevity. We have a panoply of drugs, but these foundational 4 drugs are of immense benefit because they are disease-modifying drugs. And the ACC has given a preferential recommendation for some drugs, which we'll see. All of us know 1 out of 3 patients are readmitted in India. 1/3 heart failure patient die within 1 year during their productive life years. And every hospitalization, every rehospitalization takes the patient closer to death. So minimizing and preventing hospitalization for heart failure is a great achievement in the treatment of heart failure. And here you can see that in the Indian patients, also in the West, suboptimal GDMT is not uncommon, and this is a very important cause of increasing mortality in patients with heart failure. And here you can see on the upper graph, there's suboptimal treatment, and in the lower graph, there's optimal treatment. There's a tremendous difference in the mortality, and this, therefore, the ACC 2021 brought about expert consensus decision pathway for the physicians and the cardiologists. And there are several new messages from this consensus pathway. The first big message is that ARNI can be utilized as a de novo therapy in patients of HFrEF which are naive to ACEI or ARB, and avoid the policy of switch from AC inhibitors or ARB to ARNI and initiate it directly if possible and feasible. The second big message from this is that ARNI or sacubitril/valsartan is very effective in reverse cardiac remodeling, as was documented in the PROVE-HF trial. And as you can see, there is great reduction, increase in the LV ejection fraction by 33%, left ventricular end diastolic volume decreased by 14%, end systolic volume by 25%, the left atrial volume index decreased by 20%, and the E by E prime ratio also improved. The third big message from ACC consensus is that sacubitril valsartan has shown that it can transform patients of HFrEF who are eligible for ICD implantation, which means their ejection fraction is less than 35, to ICD ineligible patients due to marked improvement in the cardiac reverse remodeling, which increases ejection fraction to more than 35%. And this is the data which I'll share with you. Now, these are 613 patients, ejection fraction less than 35, clearly means they are eligible for ICD implantation. But if you look at the end of 6 months, as many as 32% of these patients, the ejection fraction increased to more than 35. And at the end of 1 year, 61% of patients increased their ejection fraction to more than 35, which means they are now ineligible for ICD. And this is a very exciting data which needs confirmation in subsequent trials, because ICD is a very expensive device. And during this 1 year period, no patient died of sudden cardiac death. And this again shows that sacubitril valsartan is a very powerful agent for reverse remodeling. You can see at the end of 6 months, the ejection fraction has increased by about 10%. And at the end of 1 year, the figure goes to 20% or so. So in our day-to-day practice, it seems that ARNI should be optimized first before considering an ICD implantation. And I'm sure in times to come, more data will emerge out. The message number 4 is that sacubitril valsartan is recommended by ACC 2021 as a preferential therapy for HFrEF. And it is recommended that it should be started as a de novo therapy if your patient has HFrEF ejection fraction less than 40%, NYHA 2 to 4, and it can be administered in conjunction with other drugs. So if you want to initiate ARNI, if previously a patient is on AC inhibitor, you have to stop 36 hours before initiation, and you can select the initial dose of AC or ARB. If the patient is taking equivalent to less than 10 milligram of enalapril or equivalent of less than 160 milligram of valsartan, you can initiate ARNI with 50 milligram twice daily. If the patient is taking equivalent of greater than 10 milligram enalapril or equivalent dose of more than 160 valsartan, you can even initiate 100 milligram twice daily. And in 2 weeks, you can assess the tolerability and if possible increase dose stepwise to target 200 milligram twice daily. Blood pressure, eGFR, and potassium level, of course, has to be monitored. Initiation of AC and ARB is only done if ARNI is contraindicated, not tolerated, or inaccessible. So this is to be considered only in ARNI ineligible patients. And if you want to initiate AC and ARB, I think all of us are very familiar with. Beta blockers are also recommended along with ARNI in patients with HFrEF, and these are the 3 approved beta blockers by guidelines. Bisoprolol 1.25 milligram. Once daily, you can build up to 10 milligram. Carvedilol 3.12 milligram. Twice daily, you can gradually increase. And metoprolol 12.5 to 25 milligram, you can build up to 200 milligram per day. Consider increasing dose of beta blockers every 2 weeks until the maximum target dose is achieved. Heart rate, of course, blood pressure has to be monitored, and so also the congestion after initiation. Aldosterone antagonists are the third component of the foundational therapies, and they should also be utilized because they also mortality reducing drugs unless the patient has a high serum potassium or eGFR is less than 30. So we have 2 agents, eplerenone and spironolactone. If the patient, there is anticipation that the patient is likely to get hyperkalemia, eplerenone should be preferred over spironolactone for the simple reason that the metabolites of eplerenone gets cleared in 12 to 24 hours, and therefore in the event of hyperkalemia, when you stop eplerenone, hyperkalemia is likely to disappear in 12 to 24 hours, unlike spironolactone where the molecules take 4 to 5 days to disappear. So that is the difference between both these agents. Both these agents can be used, and SGLT2 inhibitors are wonderful agents. They are useful not only in HFrEF, they are also useful in HFrEF. So HFrEF patient ejection fraction less than 40% diabetic or non-diabetic, NYT class 2 to 4, and they are administered in conjunction with the other 3 drugs. And they can be initiated in a single dose, DAPA 10 milligram, EMPA 10 milligram, ensure that GEGFR is more than 10 if you are using DAPA, and EMPA has been shown to be used up to 20. And this is again a summary of what I have delivered. So let's see a case. This is an individual, a female patient, 60 years old, HFrEF since 5 years, and she is on an AC inhibitor, ARB, MRA, and beta blocker. Clinical examination and investigation, ejection fraction 30%, pulse 76, NT-proBNP 250, blood pressure 120, systolic, EGFR 60, creatinine 1 point. So obviously this patient should be shifted to ARNI in place of ACEI or ARB, because we have data from several trials that ARNI produces superior results compared to AC inhibitor or ARB. So as far as possible, ARNI should be used as the first line therapy. So it can be used as a de novo therapy in patients of HFrEF who are naive to ACI or ARB. And the reasons are it produces rapid movement in the patient's symptoms, physical function and quality of life. And the most important reason why the ACC has recommended it as a preferential therapy, it produces great reverse remodeling, increases ejection fraction, makes the patient ineligible for ICD, and decreases the chances of sudden cardiac death and the necessity of implanting an ICD. These are the reasons why it is given a preferential indication. All of us seen that paradigm-HF trial, a 20% reduction in the primary endpoint of cardiovascular death and hospitalization for heart failure on top of compared to enalapril, and PROVE-HF trial has shown marked reduction or marked reverse remodeling, and further substantiated by the EVALUATE trial. And the PIONEER-HF trial also showed that if you initiate ARNI in ADHF after hemodynamic stabilization, there's a superior outcome compared to enalapril. And the transitional study showed that 50% of the patient could achieve the target dose within 10 weeks after in-hospitalization or soon after discharge. And in patients with de novo HF, PIONEER-HF trial, in-hospital initiation of ARNI had greater reduction in heteropeptide concentration, comparable safety profile, and significant improvement in the early clinical outcome compared to those of enalapril. So because of these several reasons, direct to ARNI approach is now preferable, and we should say bye-bye to switch strategy unless ARNI cannot be used here to some reason. If you use all the 4 foundational drugs in a 55-year-old patient, you can prolong the life by 6.3 years. And if you initiate in a patient of 55 years, you can see the event-free survival can be increased by 8.3 years. And if you initiate in a 65 years, the event-free survival can be increased by 6.3 years. So in summary, the ACC recommends initiation of ARNI and beta blockers prior to MRAs in SGLT2, if feasible and possible. All 4 foundational drugs should be on board within 4 to 4 weeks or even earlier. The earlier you initiate all 4 drugs, the better is the outcome. Polypharmacy is the rule for treatment of HFrEF, and patient and family must be convinced for it. HFrEF should never be considered stable. This is a myth. And escalation is the rule for HFrEF unless side effects precludes their up titration. Thank you very much.
Hello.
Yes.
Thank you very much, Dr. Manoria, for a very lucid and talk on the treatment of the heart failure, especially of the reduced ejection fraction by RNA. I have a few questions about this talk. What is the effect of RNA on sudden cardiac death? And also, you tell me reverse remodeling data best with this agent.
See, I've already shown you that it decreases sudden cardiac by 20% as shown by the paradigm trial. And in the evaluate trial, as you have seen, that it makes an ICD eligible patient into an ICD ineligible patient. And this benefit starts as early as 6 months, and the benefit progresses further to 12 months. And during this period, nobody died of sudden cardiac death. So this is a very important message which is to be confirmed by future trials on this subset of patients.
Can RNA be used as an antihypertensive agent? As an antihypertensive agent?
It is only used as an off-label indication. Some people use it in resistant hypertension, but in China it has been approved for treatment of hypertension. But in our country, I think some of us use as an off-label indication when refractory blood pressure is not controlled.
Yeah. Lastly,
recommended by guidelines.
What is the best index of the reverse modeling?
It is end-systolic volume. End-systolic volume is considered to be the best index of reverse cardiac remodeling, although you have decrease in the end-diastolic volume also, the left atrial volume, but it is end-systolic volume, which is number one.
Thank you very much. Any questions from the audience? They may ask, please. Otherwise, thank you very much for it.
May I ask one question, please?
Yes.
Sir.
Yeah.
Sir, when a patient may need surgical intervention, at what point, according to this consensus?
See, surgical intervention is only cardiac transplant. Cardiac transplant.
Because maybe percutaneous catheterization made anything.
Now, if you have a coronary artery disease with ischemic viable myocardium, revascularization is urgently indicated. But if you don't have an ischemic myocardium, then of course revascularization is not indicated.
And sir, conceptually, is there any role of trimetazidine in this case at the cellular level?
Trimetazidine has been used both for improvement of ischemia as well as in heart failure patients.
In these guidelines or consensus, is there anywhere it is put? This trimetazidine?
It is there in the guidelines.
Okay.
It is there in the guidelines of stable angina.
Thank you, sir. Very comprehensive talk. So thank you very much, sir.
Any more questions from the audience? If not, then we close the webinar by the end of good information about the various aspects of the treatment of the cardiovascular diseases. Thank you very much, Dr. Manoria, for organizing.
Thank you to all the faculties and the chairperson, and hope to meet you soon. And we are organizing the Second World Congress in Mumbai at 5th and 6th February at Hotel Leela, and all of you are invited. Thank you very much. Bye-bye. Good night.
Thank you. Good night, sir.
Thank you.
Thank you, sir. Good night. Good night.